We are starting with the lecture of Dr. Malaysia.
Concerned persons are not able to आनी पा रहे हैं मतलब जो भी बोल दो अपने आप
चलो
9 बजे तो शुरू कर देना.
Good morning, everyone. District guest, this is Anas.
Accompanied by Dr. Ria, humbly welcoming you today to OF Pulse of Precision 2026, the North Zone Conclave on Mediastinal Ultrasound, EBUS and EUS, on behalf of Aryavarth Hospital and the organizing committee.
Yesterday's session were proudly and enriching, marked by a gracious exchange, collective wisdoms, and insight that truly advance our shared understanding. We are deeply thankful for your thoughtful engagement, insightful queries, and steadfast presence.
Organized modestly by Dr. Manvendra Sharma, Educational and Charitable Trust at Aryavarth Hospital, this conclave seeks simply to nurture open dialogue and patient-centered learning.
With sincere gratitude, we honor our esteemed chairperson and faculty for their selfless contribution of time and expertise, and all delegates for gracing us once again. Our participants trends truly meaning to our efforts.
Our quiet appreciation also extends to Solaris, a division of Sun Pharma, for their kind and steadfast support.
May today's proceeding offer gently yet valuable guidance, practical wisdoms, and enduring connections. A warm, humble welcome today too. Thank you, and you may your day proud.
Since it's heavy fog outside, the concerned persons are not able to come yet. So we are starting with the lecture of Dr. Malay Sharma on the topic of endoscopic ultrasound of endobronchial ultrasound, complementary or competitive.
Dear friends, good morning. Because of the heavy fog, we are constrained today. This is seldom happened in past, and all the people who were supposed to arrive are late. So we will start in the meantime. Since I am here, I will start with the topic and cover up with the issue endoscopic ultrasound or endobronchial ultrasound, whether they are complementary or competitive. These are two different fields. Endoscopic ultrasound as gastroenterologist or endobronchial ultrasound as pulmonologist. This issue can be discussed with many dimensions, but the questions that I want to try and answer are: number one, is the role of EBUS for lymph node staging really required? Is one enough? And if one is enough, what is the order of imaging? Whether it should be EUS first or EBUS first. If EUS first, can pulmonologist do it? And if EBUS first, then who should do it? In a nutshell, who will explore mediastinum in the coming years? And who is exploring the mediastinum now? Whether it is gastroenterologist or pulmonologist. Will there be a transition from gastroenterologist to pulmonologist in the coming years? Right now, this terrain was started by gastroenterologists in Europe. Initial efficacy of mediastinum were taken by people who were exploring left adrenal or abdominal masses, but then they started exploring the mediastinal masses. Transition from gastroenterologist to pulmonologist will be easy. Will pulmonologists think of this territory as their own territory to begin with and should fight aggressively for their role? Should pulmonologists learn EUS also. The pulmonologists do EBUS. Should they have EUS also? And this, in nutshell, decides are they complementary or competitive. Let us start lung cancer. What is the role of EUS, EBUS for diagnosis? This is a mass. Diagnosis by conventional approach in lung cancer approaches 65%. But EBS TBNA enhanced diagnosis of lung cancer in around 22% cases. So there is no doubt that EUS, EBUS both can enhance the diagnosis of lung cancer. We are fighting at the first stage, diagnostic stage. There is a lung cancer. Can you diagnose it? This is a lung cancer, biopsy of intrapulmonary tumor. So when the tumor is abutting bronchus, obviously, as shown in this case, that this FNAC of a tumor abutting the lung cancer is the most important step. And this will prevent unnecessary rest of the staging procedures. So if there is a EBUS is involved, then we have to, going near the bronchus, by all means, proceed with EBUS guided FNAC. The question is when there is tumor which is abutting both esophagus as well as bronchus. In this particular case, the tumor was abutting the bronchus, and that is why this FNAC was easy. Here in this case, this tumor was just above diaphragm, and the FNAC was required and easy and convenient because this tumor was easily accessible and would not have been accessible by endobronchial ultrasound. And moreover, because in this case, the respiratory distress disallowed other imaging procedures like bronchoscopy. So this particular case requires more easily a EUS guided FNAC for diagnosis. So the lung segments, for a brief second, I would like to draw the emphasis as shown in the earlier slides that the lung has segments. So once we start talking of these lung segments, we have to decide which segments of lung are close to which tumor. For example, this is a descending aorta in the first picture, and there is a mass beyond the descending aorta. Though there is no sign of invasion of descending aorta because there is a white line present, but dislocation of the mass makes it very difficult. Whereas in the next picture, there is sign of invasion of aorta. The invasion and encasement are two words which should be carefully analyzed. Generally, arteries are very thick in diameter and not easily invaded, and veins are thin in diameter and they get invaded. So the word is invasion for veins and encasement of artery. So this picture shows, instead of invasion, encasement of the arch of aorta. So this is encasement of the arch of aorta. So we should in our mind place which segment it is, but of course by means of CT scan But these images are also trying to independently place where the tumor should be and where the tumor is located so that appropriate decision management can be taken by the endoscopic, by the surgeon or the management team. Now this is what you see. In this case, the CT scan shows that there is a tumor above this arch of aorta, around the arch of aorta, and this is related to the left bronchus. Now this tumor can be easily assessed by collapsed epicoccygeal segment, and this tumor is encasing the left pulmonary artery. This is the arch of aorta. Below this line, this becomes descending aorta. So this is the arching aorta that you see, and beyond it is the collapsed segment. So we have to start assessing how a tumor is related to the vessels and then appropriately stay. And this seems easy because when this case, the FNAC was done through the arch, it was possible to make a diagnosis. When we are talking of endoscopic ultrasound, how do we divide the stations? Endoscopic ultrasound, we have to divide the stations generally with 6 stations. The first station is above the arch. Second is at the level of arches. This level of arches, this is a diagram seen from behind of the heart. And this level of arches means that this is the azygos vein arch, this is the arch of aorta, and this is the brachiocephalic vein, left brachiocephalic vein, which crosses in front of the 3 great vessels of neck. So this is the union point of left brachiocephalic vein with the right brachiocephalic vein. You must appreciate one anatomical fact about this station 1, that this station 1 includes 3 great vessels of neck. This station 1 includes the point of joining of left and right brachiocephalic vein. The left brachiocephalic vein crosses in front of the 3 great vessels of neck, and the right brachiocephalic vein is a vertical vein. The left brachiocephalic vein is a horizontal vein almost joining at a right angle. The next station is the arch of aorta. So when we see this next station, arch of aorta, we will find that this has got 2 interesting things, 2 arches. The azygos vein arch over the left bronchus and the azygos vein arch over the right bronchus and the arch of aorta over the left bronchus. So once we see the arches, we should be able to identify the upper and lower border of the arch of aorta. So this is popularly called second station, the station of arches. Now we come to below the arch, below the aortic arch. Of the 2 arches, aortic arch is more easy to identify, and the azygos vein arch is more difficult to identify for the beginner. The station 3. The station 3 is all about pulmonary artery. In this station 3, we must realize that the pulmonary artery cannot be seen throughout the whole of the bifurcation point. Once we see this station 3 here, we will find that this part, this particular part where you see this black line, whole line from above, is sort of an area where imaging cannot be done when you are seeing it from the esophagus, at least up to station 3. So this is the blind area of imaging in the mediastinum when it comes to esophagus, because the trachea, which lies anteriorly, covers it. When the trachea is covering up to station 3, you will be able to see only the right pulmonary artery. You will not be able to see a lot of pulmonary artery. You will be able to see the pulmonary trunk, but station 3 is all about pulmonary artery. So on the right side, you will see the 2 branches, and on the left side, you will see the left pulmonary artery, and this left pulmonary artery classically makes a Mickey Mouse sign. So when you, as I said, re-emphasize that this diagram is from behind. This is a posterior view when you are taking station 3. To summarize, the 3 stations till now, there is a station of arches, station above the arch, station below the arch. Then comes the 4th station. So I will summarize it. Station of arches, azygos and aortic. Above the arches, instead of aortic, you find 3 branches, and instead of azygos, you find the brachiocephalic vein. Station 1, the 3 great vessels of neck and the brachiocephalic veins. Station 2, arches. Station 3, pulmonary artery. So why do you categorize station 3 like this detail? Because these are the 6 rotations you must do when you are doing endoscopic ultrasound. At 6 places, you must rotate the whole scope 180 degree to assess and to evaluate. Next comes the station 4. This station 4 is most commonly and inevitably found even by a novice endosonographer. Once you come to station 4, all you have to do is follow the left atrium. It is the largest pulsatile chamber placed at 33 centimeter in the distance from the mouth. Once you see this station 4, you rotate to left, you rotate to right. On the left, you will find the left pulmonary vein, and on the right, you will divide into superior and inferior pulmonary vein. But the problem is, you should realize that these vessels, at some particular point, will become invisible. And the point of invisibility is when they enter into the root of lung. So God evolutionary has placed pulmonary artery above the pulmonary veins. And once the God evolutionary placed the pulmonary artery and pulmonary veins higher than the others, then these veins, they have to above pulmonary artery, below pulmonary veins, and the left atrium. So these vessels, when we see them, will be traced only up to this point within the root of lung, and this vessel will be seen only up to this point within the root of the lung. So you can appreciate whole of the left atrium, which in a transverse diameter is approximately 3 to 5 centimeter, but then divides into pulmonary veins. Then the area comes below the left atrium, and this should be rightly called as the area of the right atrium. It can also be called as the area where the walls are involved, where the walls are placed. So the walls are placed in the area of valves. Okay. So it is the area whereby left atrium will lead into left ventricle, and then the aortic arch will start from this place, and then from the right atrium there will be right ventricle, and then so this is the area of valves. Station 5 is the valve area, and then the last station belong to the left ventricle and IVC entry into the right atrium. To summarize the 6 station, above arches, below arches, left atrium, area of valve, and area of IVC and left ventricle. So these are some images, EUS image and EBUS image that we see. The EUS image shows they are similar. The only thing it wants to show is that the diameter of this lesion, imaging of this lesion is much bigger than the imaging from the other lesion. So here is what we see. EUS can detect mediastinal invasion. The lung tumor can get invasion of mediastinum. The heart or individual vessels may be invaded, and role of EUS for invasion is not clear, but endoscopic ultrasound is the most sensitive test detected for assessment of invasion of lung cancer. So where is elastography? Elastography has a role, and the color map that we see in this color map of elastography, they vary. 1:255 scales are seen, and you can find whether this tumor is elastographically. So lung cancer, we can restage after the diagnosis, and the role of restaging lung cancer can be discussed later on. It is a bigger topic. EUS can do FNA even if EBUS cannot, because this is where we see this is arch of aorta, left common carotid artery, left brachiocephalic vein, and this is a mass which eventually turned out to be a thymolipoma. And here also by EBUS scope also it was seen. In this particular case, the biopsy could have been done through the EBUS scope. The biopsy was done through the EUS scope, and in this case we want to say that the biopsy of such masses can be done by both the routes. So EUS can, even if bronchoscopy cannot, as we have already shown, if bronchoscopy cannot do, this 76-year-old man had respiratory distress. CT scan showed mass in lower lobe, and EUS showed tumor invading inferior vena cava, from which a biopsy was done. So EUS and EBUS can make a difference. Both can make a difference. And where do the lymph nodes lie? Which one we can detect by EUS? Which one can be detected by EBUS? And which one can be detected by both? As the principle we said that some lymph nodes are N3, N2, N1 depending on the mediastinal staging. What is N3? It's metastatic, much more distant, N2, N1. Broad principle is that lung has a central mediastinal compartment. The central compartment of mediastinum. This is the peripheral compartment of mediastinum. So any lymph node which goes beyond the peripheral compartment of lymph node to central compartment does not remain operable. So this lymph node, the issue was raised that if there is a cervical lymph node, you can do FNAC. Yes, by all means you can, because you can see this is trachea, cartilage, this is the thyroid gland, this is the left common carotid, left internal jugular vein, and you can easily, this thyroid gland, you can see this is the lymph node, and this lymph node can very easily be assessed, punctured by the neck ultrasound. So this picture shows, yesterday we had done in this case a paracardiac lymph node biopsy which demonstrated pus. We will be hopefully giving you the results of the FNAC soon. So this particular area, this was a supradiaphragmatic, paraesophageal, paracardiac lymph node. And then there was an issue was raised, what is a station line lymph node? This particular lymph node is a station line lymph node because station line lymph nodes lie in pulmonary ligament, and the pulmonary ligament is an inferior extension of the root of lung which goes all the way to the diaphragm, almost all the way to the diaphragm. So once you trace the pulmonary veins, below the pulmonary veins, whatever station you find is station 9. From a lung cancer point of view, there is no difference in staging of pulmonary staging of cancer for station 8 or 9. Station 8 and 9 both are paraesophageal, both means the same thing. Same thing. Both means so far as operability is concerned. For a lung cancer, both will denote a more advanced staging station 8 or 9. But whether 8 and 9, 8 is, this would be considered paraesophageal, maybe 9, 8, and this would be considered 9. This is the differentiation between station 8 and 9. So the orthopulmonary lymph nodes, for lymph node at 5, EBUS only is possible. This is 5 versus 6 because this is the arch of aorta, left pulmonary artery. This lymph node between them is 4L. The lymph node between these two is station 5 or 6, and this 6 is considered between the upper and lower boundary. This 5 is between the lower boundary of arch and upper boundary of left pulmonary artery. So this lymph node is a combination of station 5 and 6 lymph node, 5 or 6. And if you want to do, if it is a small lymph node and you want to do FNAC at this place, what you do have to do, you have to bring your EBUS scope here, move it maximally up, and then through this ligamentum arteriosum, go and puncture this lymph node. Alternatively, you can use it by going through the arch of aorta and this. However, EBUS scope, the only route available is by going through the arch of aorta. Subaortic route cannot be easily approached by a lymph node for a lymph node puncture. So the subaortic route is not acceptable for a lymph node puncture. Transaortic route is available for 5 and 6, and subaortic route, supraortic route is also possible for a lymph node puncture when we go above the arch of aorta. So again, this collectively are 4, 5, 6 lymph node, station 4 below the arch of aorta, above the left pulmonary artery, medial, 5 lateral to ligamentum arteriosum, and 6 lateral to arch of aorta. So this is an example where we have done a transaortic FNAC, and this is the transaortic FNAC going through the arch of aorta into this mass, and once we have to, you can do FNAC by going through a transaortic route for this. When you are doing a transaortic puncture, you must be very clear that you go exactly through the middle of aorta. If you go through the side part of aorta, you will unnecessarily puncture and shear the vessel, shear the arch of aorta. So EBUS may or may not approach this lymph node. These are the 3A lymph node 2R, and station 4R. So this controversy was discussed, but I would say that 4R lymph node was shown by us, but yesterday 4R lymph node FNAC was done by ORS. So EBUS, if you know, the pretracheal lymph node definitely cannot be assessed. And yesterday it was shown that how a transsternal FNAC can be due to a lymph node. A word about the lymph node lying anterior to the great vessels of neck, which was inaccessible. So this is the great vessels of neck. However, this is the subclavian vein, and this is station 3A. So this is when we want to clarify the borders are important because this is the sternal notch. This is the left brachiocephalic vein joining, and left brachiocephalic vein joining the internal jugular vein. The lower border of brachiocephalic vein decides the joining decides the upper border of the station 2A. In this area, the lymph nodes are divided anterior and posterior, and you can. So this classifying this collectively, this lymph node will be considered as 3A above the arch of aorta anteriorly, 3A, 6, 4L, 5 here. We have discussed that this yesterday. This is the left atrium, left ventricle, and the right pulmonary artery classically divides into an embryo-shaped structure, whereas this is the right pulmonary artery, this is the left, this inferior branch, superior branch, and superior branch is popularly known as truncus anterior. And this truncus anterior crosses over the right bronchus, and this is the superior vena cava. So these are the stations that are shown in the diagram: 10R, 11S, and 11I. The subkernal area as an oblique boundary between the origin of the left bronchus and left lower lobe bronchus and right lower lobe bronchus. And this is the distance from this place to this place is 5 centimeter. This place to this place is also approximately 5, and this is also. So the subkernal space is sort of a triangle which is made of about 5 centimeter diameter, 5 centimeter diameter on each side. So this is a triangle, and in this triangle we need to find out how the things move, how things move, and so this is may light in station 7 or 10. Does it make a big difference? Yes, it makes a big difference because station 10 is operable, station 7 is inoperable. So this decision on operability versus inoperability is major. So is only US enough for N and M staging? Yes, we have not been able to show, but in this case we see that there are sometimes tumor metastasis in the liver, and they can be picked up. You can pick up celiac lymph node, left adrenal, left lower lobe, station this metastasis, intrapulmonary thrombi, and mediastinal tumor invasion. Lung cancer, you cannot live without mediastinal tumor. So lung cancer, we have confirmed, let us stage it, let us restage it, and these are the positions by which you can stage the lymph nodes of the lung cancer. We have published this article, the standard techniques of imaging of ISLC border in 2011, Journal of Bronchology, and that is how we started deciding how to map the borders by EBUS. The earlier mapping of borders by EBUS has been defined by Dr. Anima before that. So let us combine EUS and EBUS for staging, and there are many more newer studies, and the US and EBUS combination works well for staging. So EBUS TNA, US FNA, a combination works, and this combination works really well so far as staging is concerned. So 2-in-1 scope is improvisation or maltreatment of US scope. So combined transbronchial and transesophagealization. So this 2-in-1. So to combine or not to combine is the question whether we gastroenterologists, pulmonologists should both work together. Additional equalities, pulmonologists combine. Only experts can do combined imaging. What I mean by combined imaging is use EUS scope for and EBUS scope. So is EUS a standby pathway for FNA? Is EBUS scope a standby scope? So we have used these questions, and the question remains we will answer that the vision is much wider when it comes to EUS scope. The EUS scope is size 15, 7.3, range of view 120 degree, 50 to 70. Quality of EUS scope is better. EBUS scope has less number of crystals, and the change of axis when you are doing FNA is possible, because when you are doing FNA, you have only one axis, your dull axis. You cannot change axis, where the elevator within the EUS scopes allows a change in axis. So both are needed, EUS first or EBUS first. This order is not settled. Sampling of EUS is possible definitely by EUS, TBNA, USFNA. The order for selection can lymph node, which can be present in multiple stations only when we combine, we can fine tune, and when experts do it. But so this is what we have. May be considered USFNA, we consider the first test because it is easy, it is safe, may become detectable if a USFNA is available. Bronchoscopists today, in my opinion, need 2 scopes, and they must learn the techniques of doing EUS within EUS scope, EBUS within EBUS scope. Even if the results are satisfactory, the means may not be justified. So in the era of EUS and EBUS, where is TBNA? Yesterday we have been answered partly that this technicality-wise, this is definitely standard techniques of EBUS have been described in 2010 by us, and EBUS TBNA is definitely, EBUS TBNA is definitely superior to transbronchial. So why guided EBUS FNA or EBUS and not TBNA? This question has been answered, because if you are entering the lymph node without guidance, especially when it is 10R, it will be a disaster. It can be a disaster. And too many vessels make blind TBNA difficult. So this is big node. When we are doing blind FNAC, this big node may be punctured and you can get only vessel. So guidance avoids problem, because TBNA the essence of minimally invasive technique lies in its selection and not in duplication. Whatever you want to do, if you can do a single test, that is much better. So this is takeover from gastroenterologist to pulmonologist. Is it a takeover? I don't know, but I can say gastroenterologists did start way early in 1998. And EBUS, I don't know, but probably the audience can tell you when was the first EBUS FA team. We started way back. So chest physicians can obtain. So this was the first time when a popular physician of Europe, he said chest physician can obtain results similar to those of experts and nodal stages. So we don't mind, because already I believe most of the gastroenterologists are busy. Well, but let us walk together and let us see what is stopping the pulmonologist. However, widely over a north range, though EBUS has evolved in a big way, at least in North India, compared to South or West or East, but it is the culture, it is the regulations, it is the thinking, it is the thought process. The people, the awareness of EBUS is probably much more, I believe, in North India as compared to South. The culture, the pulmonologists still carry a barrier of learning EUS, and the regulation, so they may EBUS TBNA or. So these are the three things which are inhibiting us. Something is blocking the pulmonologist. So these are the stations that we decided when we wrote this article, 6 stations, respiratory landmark, 1, 2, 3, 4, 5, 6, respiratory, arterial, veins, lymph node, vertebral, pulmonary landmark. Having answered all these questions, we come to the final part of the summary. The questions is EUS, role of EUS for and the answer. EUS, EBUS for lymph node staging, both are needed. Is one enough? One may be enough. Order of imaging, EUS first, unless it is 2R or 4R. I would say maybe if you want to do, use the EBUS scope through the EUS first. EUS first or EBUS first, to each his own. Whatever a patient comes to us, we do it, but EUS first or EBUS first. If EUS first, the problem is we don't mind, but my thought is, yes, pulmonologists should start doing EUS if they have availability of a larger scope. And if EBUS first, we should do pulmonologist. So I would like to hate that the territory, but yes, the territory is surrendered. Generally, gastroenterologists will not be able to easily enter the bronchus, but the pulmonologist will enjoy the luxury of going through our territory and charting through our territory. So we will explore mediastinum. Again, both comes with a question. Both may not be able to, both can explore, but we will not be given the limited passage through the bronchus. Pulmonologist more or gastroenterologist more will be transition. Yes, there is a transition. There was a phase where mainly gastroenterologists are doing mediastinal. Will transition be easily, and should pulmonologists learn? I have no doubt. I have no doubt that pulmonologists must learn endoscopic ultrasound. They must learn. There is no two answer. Is US and no, they complement to each other. So this mediastinoscopy is even complementary to EBUS. So the technical barriers are all. So the tumor abuts esophagus, tumor abuts trachea, and tumor abuts esophagus. So then what is the reason? Tumor abuts esophagus. So these are the questions we have answered, and this is. So we will be doing the next workshop soon, and then hopefully we will decide what is, wherever it is done. I would like the workshop is done soon at some place other than our center, so that there can be a rotation and there can be knowledge sharing and there can be enthusiasm and there can be development of mediastinal EUS as a whole. Thank you very much.
Thank you, sir, for the wonderful speech. For the next session, I would like to call Dr. Rehbar Khan, sir, Professor and Head of Department of Respiratory Medicine, to please take on the seat, sir. And I would also like Dr. Sangram, sir, who is a Senior Consultant at Aryavarth Hospital. Please, sir.
For the lecture, I would like to invite Dr. Viruttam Tomar, sir, Director and Consultant Pulmonologist at Dr. Shivraj Memorial Chest and Allergy Center, Meerut, and also, he is also the organizing chairperson of Pulse of Precision 2026. Please give them a huge round of applause.
So, very good morning, all of you. I hope yesterday you have enjoyed a lot of EBUS and EUS cases in workshop, live cases, and I welcome you again. Today is the second day of this EBUS workshop conference. So today I will discuss the step-by-step approach, how convex EBUS scope works and how we can utilize this modality in sampling mediastinal lymph nodes. So basically, as we all know, the EBUS was developed to diagnose the mediastinal lymph node, to assess the mediastinal lymph nodes, but other diagnostic tests can be used, this utility for intrapulmonary tumors, for unknown hilar and mediastinal lymph nodes, mediastinal tumors and cysts, vascular structures, and even therapeutic uses is also done by endobronchial therapies, by some endovascular thrombolysis, and beyond diaphragm, beyond mediastinum, we can reach to the pulmonary parenchyma, lung abscess drainage, pericardial effusion aspiration, and paravertebral abscess aspirations, and as Dr. Malay showed, even liver metastasis, you can access liver adrenals by the EBUS scope. So we all know, as Dr. Malay said, that the EUS has started way back, but I can say that radial EBUS was available since 1990, and the first paper was published by Dr. Baker, Fushikawa, and Hirth. They all started in 1999, the convex probe EBUS, and India, I think 2010, first EBUS scope was there, and later on here and Delhi we started in 2011. So almost more than 15 years we are doing this EBUS, this part of India. The how popular is TBNA? We all know the TBNA was used before. This is a blind procedure, but the one survey was done by the North American Society. They found that 12% use TBNA in malignant disease and 2.3% of non-malignant disease. 50% have rarely used TBNA. In 1999, almost after 10 years, American Association of Bronchology surveyed that 54% performed less than 10 times in preceding years, and 18% never utilized it in the prior year. So what was the hitch doing this TBNA? The problem of technique. They found in 30% of cases a belief that TBNA is not useful, and the sensitivity specificity, you can say, ranges from 40% to 70% hardly. The lack of rows to assess the adequacy of specimen, 14%, and the most important is physician may fear that they may accidentally hit the vital structure. So most of the time TBNA was used to access the lymph nodes of station 7 and 4R lymph nodes, but they avoid using this TBNA blind technique for 4L lymph nodes where the arch of aorta and all great vessels stands. So factors that affect the yield of TBNA, The successful TBN involves thorough training of whole mediastinum. We should know proper mediastinal structures, understanding the instrumentation, technique, experience, lymph node location and size on site evaluations, thorough knowledge regarding the relationship between the tracheobronchial tree and association mediastinal and vascular structures. So we can say it is a curtain raising. What you cannot see beyond the curtain by EBUS, you can go by the ultrasonic images, you can see properly the different structures beyond the bronchi or tracheobronchial tree. As Dr. Malek said that both are required, any pulmonologist who doing EBUS should do the EUS also. So what you can see here, the ACCP guidelines regarding the mediastinoscopy. In 2007, they prefer mediastinoscopy over EUS or EBUS TBNA. But in 2013, ACCP guidelines clearly said the EBUS TBNA or EUS TBNA is recommended over the surgical staging as the first test. Again, very important declaration by the combined European Respiratory Society, European Society of Thoracic Surgeons and Gastroenterology Endoscopic Society. What they said that the combination of endobronchial ultrasound, that means EBUS TBNA and EUS TBNA scope, is preferred over either alone test for complete mapping of the lymph node. And this clearly said that individual endoscopists should be trained in both EBUS and EUSB in order to perform complete endoscopic staging in one session. So here, in this part of India, in Meerut, we started this way back in 2010, doing this combination of this EUS training for the pulmonologist, like what later on called EUSB. So requirement of EBUS is the same like in the bronchoscopy suite. It's a sterile procedure like in bronchoscopy that can be performed, and basic structures, trolley, oxygen, cardiorespiratory monitoring system, full resuscitation team. These are the basic requirements, but later on you can add on C-arm and all that thing what you can have in your hospital. So staff minimum, at least 3 staff is required, and 1 floater can be helpful for utilizing that person for your help, but minimum 3 persons are required. Patient preparation is like same as bronchoscopy. You have to see properly the CT scan images, ECG, basic test, bleeding profile test, and informed consent is important. The instrument is important that we are having in India, we are having both type of instruments like convex probe EBUS and radial probe EBUS, and different companies like Pentax, Olympus, and the Fuji is having this both type of EBUS. But I prefer for beginners to buy only the convex probe EBUS, because radial EBUS still is a blind procedure and takes lots of time to take the sample from the peripheral nodules, and this is the hindrance, and sometimes you get frustrated when you don't have you have larger time to get FNAC of peripheral nodules, but CP EBUS is a hardly few minutes procedure, hardly 10 in 15 minutes you can get a sample of the mediastinal lymph nodes. The region wise, as Dr. Malek said, that in the North India you'll be surprised. When we started in 2010, hardly 3 centers were here in north part of India, but later on this year I've got this slide, this number from the different companies. Delhi NCR having 60 EBUS in this part of India. So there is a little bit difference between the Olympus, Fujifilm, and Pentax, and you can see the Olympus is having the hybrid scope that is not fully video scope, while the Fuji having beauty of almost 10-degree oblique view, while Olympus having 20-degree oblique view, Pentax having 45-degree oblique view, and little bit difference are there, but you can see we are having the opportunity to take all these type of instruments. Needles, the Olympus is having EG short needle starting from 21, 22, 19 gauge needle, and even 25 gauge needle is available world over. Mediglobe having this, I have used this Mediglobe, is very sturdy needle, but it's not easily available nowadays. This needle is again very beautiful needle, Cook needle, very sturdy, and we can use having Procore also, so you can take biopsies from that needles. So choose correct needles. Imaging is important. Before starting this imaging of by EBUS that can be performed either in local anesthesia, and since 2020 with the Olympus 190 scope, I am using the nasal route like bronchoscopy route with simple local anesthesia, white spray. I am not using any conscious sedation, but definitely for the beginners and for getting early access, you can use general conscious sedation, you can use LMA, and all the preferred choices. What in your hospital practice you are doing with for bronchoscopy, you can utilize. And that this procedure can be done in supine, like in bronchoscopy position, in the lateral position. So as you having equipped more experience, you can do from any position. The important thing here is when we do the local anesthesia on vocal cords, EBUS bronchoscope passed carefully through the vocal cords because it is having the oblique view. So when you are traveling like in this hall, you are not seeing in front of it, you are seeing the ceiling of this room. And that this way, when you reaching at the vocal cord, you have to just see the anterior commissure of the vocal cords and just slide down. You will be in the center of the trachea, and again deflex, as in workshop yesterday or today we will show in the workshops how to do this and how to negotiate the vocal cords. The anesthesia I have already mentioned. Technique, how to hold this EBUS scope is very important. How to hold the needle and how to attach this needle to the EBUS scope is important. Attain thorough knowledge before doing this EBUS with different anatomy books, which you have learned in the previous MBBS first year days. Very important to go through and attain the knowledge with interaction with different expertise of from world over. I have opportunity to be with these galaxies of interventional pulmonologists. And these are the few education projects that are available online. You can go through and take the basic knowledge of how to start EBUS. The angle of examination is important. You can see here, this is the tip of the EBUS scope, little bit different from the bronchoscope. Here you can see the needle comes out from the tip at the particular angle. In Fuji scope it is in 10 degree, and in Olympus is almost 20 degree or 35 degree, and Pentax is in 45 degree. And later on you can see in the ultrasonic images, very important to know about the basic ultrasound, what are the hyperechoic shadows, what are the hypoechoic shadows, what are the isoechoic or anechoic shadows, so that you can access or you can differentiate between the vessel and the lymph nodes properly, and how this needle comes out from the scope in the ultrasonic image. That all is important. So skill required before EBUS is the diagnostic and therapeutic flex bronchoscopy is essential. You should know the basic knowledge of how to do conventional TBNA. Rigid bronchoscopy is optional. Ultrasonography knowledge is important. Fluoroscopy is optional. So with proper history and radiology examination, you can start EBUS. And as Dr. Malay said, if you are having stations just for making a diagnosis, not for staging of this lung cancer, or you are want to sample station 7 or 4L lymph nodes, even without going in the trachea, you directly go put this scope in the esophagus and get the access of the lymph nodes very easily. So it's your choice which type of practice you want to do for diagnostic purpose or for as a mapping of the mediastinal lymph node. If you want to do lung cancer staging, you have to do the proper EBUS through the trachea. Again, the EBUS scope, the few settings is very important to know. In the ultrasonic equipment, what you are having, what is gain, how to increase or decrease the gain, and what is the benefit of decreasing that gain. You can increase the image brightness by increasing gain, and when you decrease the gain, you can decrease the brightness of the images. How much depth you have to put so that you can see the beyond the mediastinal lymph nodes, or you want to see distal structure of the mediastinum. How to put the focus and frequency, how you should know that there is an inverse ratio, you can see the link between the frequency and the brightness, or you can say if you are increasing the frequency, you cannot see beyond the airway much deeper, but when you decrease the frequency, you can see better the distal structures very beautifully. Balloon, I am not using balloon, but these standard stations of imaging with linear scopes, as Dr. Malay presented in his previous slide. So it is important to steps in TBNA. The positioning of scope is important. How to fix this needle over the scope is important. There are the few locks in the needles. So when we advance this sheath in the needle, it's a very important step that you should see the sheath is out or not when you have attached this scope, this needle to the scope, and you can see that the crescent shape sheath should be visible at the tip of the endoscopic image of your scope to avoid the injury of the scope when you are putting this needle inside the. When you have make assembly of this scope, EBUS scope, again we have to search the lymph node, because when you are seeing this endoscopic image, sometimes you miss this endoscopic image, so you have to again search this lymph node by the touching this probe to the airway. Important step is release the needle depth lock, and you can even size before puncturing the lymph node, that how much size of the lymph node. If that is a 3 centimeter size lymph node, you can fix this needle length 2.5 centimeter to avoid puncturing distal structures or vessels. So important is to lock the depth of the needle. These are the few techniques I will show in the today workshop, but that is important how to do the EBUS FNA technique. I am not displaying this video for lack of time, but when you have entered into the lymph node when puncturing, very important step is that you have to put the Doppler over this lymph node to avoid any vessel is in the pathway of the needle. So put Doppler and do the to and fro movements, at least 14 to 15 movements, and you can apply negative suction to aspirate, or first puncture should be without suction. And recent studies said there is no role of putting negative suction. You can have almost equal material in sarcoidosis, tuberculosis, and lymphomas, even without putting the suction. So you can do that without suction or with suction. That's your choice. Rose is very important, and so I am not showing this video because lack of time, but I will show these all things into the workshops in live cases. So the 10 steps, you can say: visualize the target lymph node, advance sheaths till slightly visible outside the scope and lock it, access the lymph node size and lock needle at the appropriate distance prior to advancing, visualize needle as you jab into the node, remove stellate after moving in and out a few times, and attach syringe with suction on, zap 10 to 15 times in node, suction off and remove needle back to the neutral position, remove entire needle sheath assembly and place material on the slides. So by that way you can do this is a 4R lymph node. You can see here SVC, and you can do the FNA of the 4R lymph node. And this we all know, since yesterday we are seeing this type of diagrams, how the different lymph node stations are we can classify. The oncology midline is along the left border of the trachea. You can see here from anterior trachea the 4R to the lateral wall, the 2R and 4R. However, up below the carina, this central line is actually in the central, and you can see how you can see these different lymph nodes by combination. Almost all lymph nodes can you sample when you do EBUS and EUSB. 2R important. I am not repeating. I think this is a left brachiocephalic joining, the right brachiocephalic when it makes the superior vena cava any lymph node above on the anterior to lateral sides 2R. Below this joining of brachiocephalic is 4R, and up to carina, where the important structure comes, that is the 10R, that is the azygous vein. You can see here the azygous vein is an important structure that is above any lymph node is 4R, below azygous on the right side is 10R, while on the left side the any lymph node above this aorta and up to the neck is 2L, and below this aorta and up to the left pulmonary artery is 4L. Later on you can see this is the 10L. The 10L is below just pulmonary artery, and station 7 is subcarinal lymph node. When you touch your scope to the any wall of carina, you can see these type of lymph nodes. So this is the basic mapping. So I'm not going to discuss all these lymph nodes step by step. I will show this in the video, in the live cases here. So thank you so much. Any question you want to ask? Local anesthesia. Yes. It is more easier and more safer, like in TBNA. When we do usually TBNA patient, we usually do in the local anesthesia, and with expertise, even you can do. I can show here if I'm having this. No sedation is like bronchoscopy. I'm using this. Today I missed that my lecture. I will show that is very easy. And 190 scope is like outer diameter is almost 6.9, so you can easily go. And since 2020 post COVID, I am using 99% cases I am doing with the nasal route, like bronchoscopy, without any problem. Either you can take 15 minutes or 20 minutes, it's your choice. But no more pain. 6.9 is very small scope, and if you are having difficulty, you can go with the oral route, but do in the local anesthesia. The purpose is not mine to propagating this technique but it is a ease. You are not dependent to the anesthetist or another team, and the risk of anesthesia, even conscious sedation, is very high sometimes. Even in severe COPD patients, comorbidities, CAD patients, MI patient, ejection fraction 20%, 15%, you can do easily without even coughing. The simple way, as you trained in the doing bronchoscopy, we have never used the sedation in my practice for bronchoscopy. Same 10% spray, 2 spray in the vocal cords, and when you go inside by putting jelly, and when you enter, just spray when you go through 1% xylocaine on the vocal cords on both sides, and as you go inside, spray again the same way. But it's a very beautiful, very safe, and patient will be comfortable. Here we are not having 190 scope, but if you are having the thinner scopes, latest one, that's quite easy to do within local anesthesia. There's no problem. Thank you so much.
Live. We are going live. After that.
Thank you so much, Dr. Virottam Tomar sir, for such a wonderful lecture. And thanks to our chairpersons, Dr. Singram sir and Dr. Rahbar sir. Now it's time to go ahead for our first live demonstration session. Please be attentive and feel free to ask the questions within the interaction.
because of the fog and all. The other cases were unable to come. And the fog has disrupted our proceedings. This is seldom that North India has been hit by such a fog. So the fog has disrupted our proceedings on the second day. So we will start with the case, and Dr. Praful will initially brief about the case to the audience.
57-year-old gentleman. So this is a 57-year-old gentleman presented with us with a significant weight loss, cough with expectoration and pain abdomen. He has no abnormality, no comorbidities. CT was done outside, suggestive of a significant mediastinal lesion. So over to you, sir.
Prove me now.
आप एक बार जाओ.
So this is the scope that we see, because we have discussed in morning that the EBUS probe is bigger than the EBUS probe, and in this case, what happened? When this patient started coughing a lot, and once we started coughing a lot, I had removed this scope, and I had to remove this scope, and I waited for some time. So so we removed the scope for sedation to take a proper effect. So now I am introducing the scope, reintroducing the scope into the mediastinum, and see. We will be careful that this patient may be having discomfort. This is again disappearing something. So you move this. Here, Hildra, this is coming. Under. No. This. So, this case we are now trying to find out what is happening. This is the aorta, arch of aorta, and this is a mediastinal mass. So we are trying to quickly find out what is happening to this mediastinal mass and whether this mediastinal mass is behaving. We will store it and we will review this later on. And in this case, let us start. This is the necrotic mediastinal mass, and this is the area, this is liquefied, and this is mediastinal mass. We will do the FNAC first, and we are storing it because for the benefit of the comfort, we will discuss this issue later. And review, this is called frame by frame review of this case. We are reviewing this case quickly by storing this. This is the azygos vein, and we will review this case one. So we will store it. We will also try to show to the audience what is a real-time store analysis. To real-time store analysis in terms of and how to review. So we need a EBUS needle. So can we give a EBUS needle? Because this is liquefied a lot, and this so whether this is liquefied and what comes out of it. I will first apply elastography in this case to see whether there is any elastographically it is easy to make comment or not. And I will apply color Doppler here, power Doppler here, E-flow. This lymph node seems to have vascularity. The vascularity is seen within this lymph node, and we want to find out what can be done. So this is a very enlarged lymph node. Whether the vascularity is present from the center or not, the patient is moving too much, the needle. So in this case, I will write, this is the left atrium, This is the pulmonary artery, right? So the needle has been fitted, and we will finish up the FNAC part. Now once we are storing the needle, we will now try to show you what should you do before you pass the needle to increase the effective visualization of the needle. You should do 5 things. Number 1, you should apply tissue harmonic on. Number 2, you should make it as black as possible, dark, as large as possible. Number 3, you should decrease the gain a little bit. Then you should take the needle out. The needle is being taken out, and the needle is taken out is felt by number 1 by seeing, number 2 by feeling, and number 3 in our case by elevator. So we use the elevator, we push, release the elevator, take the needle out, and this patient is coughing, again coughing, so we are trying to do it fast. Yeah, then fix the needle, hold the scope here, hold the scope here, then release the, and in this case, this sometime when you don't see the needle, you rotate the scope this side or that side, you go to the lid, remove, push it in, and then remove. So we are recording this and we will discuss this issue frame by frame. So because we want to finish, so there are various ways, but the important thing we want to show is that we can change the axis, by rotating this way or this way. So this way that needed. So this leaves very easy. So this is very easy. We will remove it and see what comes. So what comes in the tissue. So now as I said, I will review this case frame by frame later on by the recorded images, so that this makes sense. This makes more sense to the audience. Now I am going quickly to the chest, lower part of the chest. Here this is the way we are recording. This is the right atrium, right ventricle, pulmonary artery, trunk, this aorta, left atrium, mitral valve, and then we'll pull it back. If that issue technique, then this is the ascending aorta, this is the pulmonary artery, and this is the lymph node. These are different parts of lymph node. This is pulmonary artery dividing into two, embryo sign, truncus anterior, lymph node above the pulmonary artery, then trying to rotate at the same time if we can find the azygos vein arch. This is the azygos vein arch, arching of the arch of aorta. If you find this lymph node above, if the tissue come, if you can find out, then rotate it there. We're just checking if there is enough satisfactory amount of tissue. And this is the arch of aorta. Enough tissue? Okay, so we'll remove it and then we'll analyze frame by frame. So now we'll analyze frame by frame, because that is what I want to show is different from the frame by frame analysis. So concentrate, Arun, last frame. So this is the frame we analyze. So in this frame, I will write this is the liver. We have gone all the way into the stomach. And this is the liver, and this is the inferior vena cava that is coming out of liver. And this is the right atrium. And this is the left atrium. And this is the interatrial septum, IAS. So we will keep these structures, and then we move this. So this is the structure, the way structures are. So this view, this frame has been recorded within this, and now we are reviewing this recording. The liver is here, the IVC is there, the right atrium is there, and this is the place we are showing. This is superior vena cava. So this, once you outline this superior vena cava and outline this area, this looks like a bag. I will outline the area of right ventricular outflow tract. This is the right ventricular outflow tract I am pointing out. So this entire area is called the RVOT. RVOT. So this right ventricular outflow tract starts from this area. So then we will move further. RVOT. I will erase these characters, erase, delete, erase these characters. So I will. So then I will continue this, and so now I will explain. Go again, get back again, because this is IVC, and this is the right atrium. This is the liver. This is the diaphragm, and this particular place we should be looking for the valve. The valve. So is there a valve? There will be a valve here. This valve is exactly at this particular place. Go out. So we'll shift the patient out into the emergency room. So this is the how we discuss. This is the advantage of left frame analysis. We keep on analyzing and keep on analyzing new facts. That is the right atrium, diaphragm, liver, and then the valve. And this we will clear the characters once more. Clear. Then we will try and analyze it once more by reviewing the. So what we now see is this is the origin of the right atrium valve. Aortic valve. This is aortic valve, and this is the origin of coronary artery from the aortic valve. This is left atrium, aortic root, right ventricle. Again, so this is. So I will rotate it back and rotate it back, because this is the clapping sign, and this area shape is the buttock shape of the aortic valve. Thus, and this is the aortic valve. And this is the origin of the coronary artery. So this is more or less becoming hopefully clear. This is the left atrium, mitral valve. So we will run it for 2 and 4th. Generally, now I will again run it. This is left atrium, left ventricle. This is the mitral valve, and this is the. So this is how you keep on running it, left atrium. You will understand that the left atrium, left ventricle, the chambers of the left ventricle are thicker, and this beyond here, this is the pulmonary trunk, the ascending pulmonary trunk, which would be arising from the right atrium, right ventricle, and right ventricular outflow tract. So as we have already shown that the right ventricular outflow tract, this is liver, occupies a place like this and like this, and the left ventricular outflow tract tends to occupy a central area around the heart in this shape. And the right ventricular outflow tract tends to take an area of around this shape. So these are the two shapes that we can Arun? Yeah. So these are the two shapes that we have now identified. So right ventricular outflow tract, left ventricular outflow tract we have identify. So this is the right ventricle, very clearly seen right ventricle here, going here, pulmonary trunk there. Now this is the right ventricular outflow tract, left. Here you can see that the left ventricle is very clearly outlined like this. Left atrium, mitral valve, left ventricle, and this is the thick chamber of the left ventricle is clearly outlined. We are probably going more in chambers, but I will now come to spaces because when the chamber part is over, this is the clapping sign, doing for clapping sign, delete. This is the clapping sign, go, it rotated back, clapping sign of the aortic wall, clapping sign of the aortic wall, and this is week 2 and 4. So right now we are having this is the pulmonary artery, left atrium, aortic wall, and this is the right ventricle fiber. So keep on moving this forth, keep on restoring, so because once the chambers are clear to you, then you can proceed accordingly. This is the case we keep on seeing, right atrium, right ventricle, and all the now here is the where that this particular lymph node starts appearing for the first time. We want to measure that this is the line. This is the line of upper border of the left atrium, and any lymph node above this line should be considered as the station 7A. So we will consider it the station 7A. So this is the this can be considered if this is a lymph node as station 8 here, and this can be considered as station 7 here, 7 here if you want to measure it. I would like to draw the attention of you all that right now there are 3 main pulsations from below upward. Slowest pulsation is the left atrium, above the left atrium is the pulmonary artery, and highest is approximately here would be the arch of aorta. So 3 important pulsations, arch of aorta. The left atrium is braces roughly at around 33 centimeter distance from esophagus. The pulmonary artery is at around 27 centimeter distance in the esophagus, and the arch is at around 22 centimeter distance in the esophagus. 22 centimeter. So this arch is not seen in this picture, but this is the left atrium pulmonary. And this pulmonary artery, this is the area where the pulmonary artery is included in the subcarnal area, means that this is the lymph node of the subcarnal area. This is the lymph node in the subcarnal area. Once we see the lymph node in the subcarnal area, this I will clear the characters, this particular area that you see, this particular area you see is the bronchus. Because the bronchus is limiting on the one wall, you can appreciate the bronchus by the fine line, this white line that is going on one side of the boundary. Because subcarnal area, I have shown you that there is a lower boundary. The lower boundary is defined by the left atrium. I want to show you the upper boundary will be somewhere here, where you will find the trachea. But there is an oblique boundary on either side which is defined by the bronchus. So this is the left bronchus or right bronchus. So this will define whether the structures close to it are pulmonary artery or pulmonary veins. So this is the right bronchus. Why this is the right bronchus? Because at this particular place you find 2 more important structures. This is the left pulmonary vein which is converging, and this is the left pulmonary artery. Why this is the left pulmonary artery? Because pulmonary artery, LPA, pulmonary artery. Because this particular pulmonary artery, when we follow it by further rotation, will divide. The pulmonary vein will be dividing into 2. This is the upper pulmonary vein, this is the lower pulmonary vein. So this will be dividing into 2. This is the pulmonary vein, and this pulmonary artery will be also branching into 2. Why this branching is important? Because as I have shown that the moment pulmonary artery divides, it enters into the lung, root of lung. So pulmonary artery divides and enters root of lung. So this particular lymph node which is said to be extensive, which is quite extensive, is 7. Here on, it is entering, whether it is entering or whether it is displacing the bronchus is not. Problem, in my opinion, this is displacing the bronchus because this lymph node is seen and the pulmonary artery is also very well seen. So this is now the bronchus. The bronchus is very well visible here. The pulmonary arteries have entered the root of lung, and this is the lymph node which is extending and displacing the subcarinal area, a very large lymph node, subcarinal lymph node mass. And you can see if you move at 2 and 4 that the bronchus, the air bronchogram continues to be visible. So this is again going back, this is the left atrium, this is the pulmonary artery, and then when you rotate it here, you can see the lymph node. Now there is an interesting thing that in this case there is a lymph node above the pulmonary artery. This particular lymph node is above the pulmonary artery. So what will you call this lymph node, which is a lymph node above the right pulmonary artery? Actually, pulmonary artery is a content of the subcarinal area, and it is still subcarinal area, but this pulmonary artery, the better definition is above the left pulmonary artery. How does pulmonary artery define the boundaries of the IASLC border? Viruttam, what will you say this is? So this will be the 4L. So this will right now, we will differentiate as 4L, and this will be the station 7 of the, we will continue it further, pulmonary artery, so we will continue this further, and then I think we are done this with this case. There is the azygos vein. This is the azygos vein. So we will delete all this structure, and this is the azygos vein we will keep on as reference point because this is the azygos vein. Azygos vein. So we will have to mark the upper border of azygos vein because a lymph node above the 4R, above the upper border of azygos vein, above this upper border of azygos vein would be considered as about this particular border will be considered as 4R. So we'll see if there is any lymph node above this border or not in this. So we will find, as I rotate it back, we found that there is a lymph node above the upper border of this, above the upper border. This is the 4R we have pointed out where the arrow is. But when we rotate it further, azygos vein, above the azygos vein, there will be lymph node of 4R or not. So this, now this is the arch of aorta, and beyond the arch of aorta we are finding these are the lung rockets. These are the lung rockets. We find any lymph node in. So this is we could store in this forum. So I think we are done with the case, and we can now resort to the next lecture. And in this case, the lesson is even if you cannot learn while you are doing it, the aim is to finish the job in a patient who is in distress, finish off the job, take the diagnosis. We have made the histopathology. The slides have shown pus or the slides? Huh? The slides have shown solid material. So this is soft necrotic material. The slides have shown solid material. We will try to have the histopathological view, opinion within the next 2 hours before you leave. But this is, and this is then you review the whole case at a later stage. So we found in this case review that the patient has station subcarinal lymph node, the patient has station 4L lymph node, and that is why we have to take fast biopsy in this case. So you can start with the next lecture there. Next lecture there in the hall, and as we finish up the case, you can start with the next lecture.
Now it's time for the lecture session. For this, I would like to call Dr. Sukhbir sir. Please come on the stage.
Also, I would like to invite Dr. Ashok Kumar Singh, sir, Director and Pulmonary and Critical Care Medicine Specialist.
For the lecture, I would like to call Dr. Rajesh Chawla sir, who is a top pulmonologist and critical care specialist at Apollo Hospital, Delhi. Please give a big round of applause.
Good morning. Thank you very much. So, I'm going to talk about a very important topic, and I think all of us as a chest physician encounter quite frequently, that is mediastinal lymph nodes. How to approach, so in next 10 minutes, I'm going to tell you how to approach when you find these. I think all of us know that we have tuberculosis very common in our country, although in last, if you see from 2015, when we had the incidence 237 per lakh of population, we reduced to 187. That is a 21% reduction. If you compare with the average overall in the world, it is 12%. We are doing good, but still we have a long way to go. So mediastinal TB is one of the component, one of the organ which gets affected, and it constitutes about, in various studies, about 10 to 14% or even 20%. And there are other conditions which are less common but can mimic, like sarcoidosis, lymphoma, metastatic malignancy, which can present as a mediastinal lymph nodes. It was a dictum when we were studying, like any lymph node you find in mediastinum, you treat them as tuberculosis. But I think as the time has passed in last 25 or 30 years, the other conditions have come up, and we do encounter sarcoidosis also, not very uncommon in our country. I think the symptoms when you approach a patient of mediastinal TB, cough, chest pain, fever, weight loss, these are very non-specific symptoms. But when they are present for 3 to 4 weeks, you start thinking that there is something wrong. And the first thing which you get is an X-ray chest. So this is the various ways how mediastinal TB can occur. It can occur as a primary TB, lymphatic spread, and mediastinal lymph nodes can occur, reactivation of TB, or occult pulmonary TB with dominant nodal disease. Most often 4R, 4L, 7, 10R, and 10L. These are the common lymph nodes which get affected by mediastinal TB. And isolated mediastinal lymph nodes with normal lung parenchyma is not that uncommon. We do not see, but lung lesions could be there in a patient, but most often they are so little or very little that you don't appreciate, and you only appreciate the mediastinal lymph nodes. So when you have a patient, you approach by history and physical examination, which give you sort of an idea that whether it is tuberculosis. You must examine patient for skin lesions, because in sarcoidosis sometimes you find the skin lesions, and you should see for the other sign which could suggest that it is a sarcoidosis. Then the chest X-ray is the first investigation you get, and you might see that there is a mediastinal, like in this you see a right paratracheal lymph nodes. You must do this. Many a times people will get a CT and not get an X-ray chest, but please do get a chest X-ray, because for follow-up the chest X-ray is important. The next test which you do is a CT, and whenever you do a CT, please do a contrast enhanced CT. Do not do an HRCT or a plain CT, because it will not give you an idea about the lymph nodes. So this is the kind of lymph node you will see in a tuberculosis, where there is, as you can see, there is a enhancement with a hypoattenuation or less attenuation in the lymph node. So these are the features in a CT chest. You will have a central necrosis. You may see, you may not see. Most of the time they are not homogeneous, heterogeneous lymph node. Peripheral rim enhancement, if you use a contrast. Sometimes you do a calcification also. That does not mean that patient does not have an active tuberculosis. Many times people will get a PET CT. PET CT, you will always get a high uptake. That's a false positive. That does not mean that it is malignancy. You could see the PET uptake. So that's not the investigation, and it cannot differentiate TB from malignancy. So there is absolutely no need to get a PET in these patients. Many times we come across patients chronic kidney disease where you can't do contrast, then you can do an MRI, which is less often used. And what will you see in T2 images? You will see the mildly hyperintense nodes. And that will confirm that probably these are active nodes. You know, MRI is a modality which can tell you whether they are inactive nodes or active nodes. When a patient has healed, you have given the full treatment, and you do an MRI in a patient of CKD where you can't do a contrast enhanced CT, you will, in a T2 image, you will find hypointense node post treatment. And that can tell you that this patient, you can stop the treatment. Many times the lymph node persists, but if in the MRI you see a hypointense lymph node, that means this treatment is enough and you can stop the treatment. So this is also a modality which could be useful when you can't use a contrast enhanced CT thorax. Everything is not tuberculosis which is looking necrotic. Many times you jump at a diagnosis, oh, it is tuberculosis. But when you get the report, it is a squamous cell carcinoma. So one of the differential when you see a hypoattenuation is the metastatic lung cancer, especially squamous cell. I have seen in a year time, I see 2 or 3 patients where there was necrotic. I was thinking tuberculosis, but because of the coagulation necrosis which occurs in the squamous cell carcinoma, you could see hypoattenuation. So don't jump at a diagnosis before you get a cytology. Fungal infections also cause sometimes these histoplasmosis is not that common in India. Cryptococcosis will also show something like this. So after that, you always get a Montus in all these pension ACE just to differentiate. But I think the test which is required is the EBUS TBNA. You know, before I go ahead, you know, when I started practice in 1988, we were using CT guided lymph node biopsy. You know, you will be surprised, people used to do it without pneumothorax. They were so expert at that time because nothing was available. But now it is an invasive procedure, of course, and variable yield, so this is no longer done. Particularly, you know, many places still may not have EBUS, but this is a modality. Mediastinal, this skill has not developed in our country that much. The yield is high, of course, but it's a surgical. So EBUS TBNA has really established because of high yield, minimally invasive. So that is the modality of choice. High accuracy, up to 92 to 98% for tuberculosis when you combine histopathology and culture and molecular testing. It is minimal invasive and sensitivity is 70 to 90%. If you see the typical features of tuberculosis, heterogeneous as I was saying, ecotexture, hypoechoic nodes, there may be central necrosis, ill-defined margins, and absent or displaced hilal structure. So these are the typical TB features. But remember, you know, they are not, it is not necessary that it will be tuberculosis, but these are what you find. Sarcoidosis, usually it's a homogeneous, well-defined. Malignancy is a sharp margin, rounded, and coagulation necrosis sign, as I was saying, that's why everything which is hypoattenuated is not tuberculosis. Key message is sonographic appearance guides suspicion but is not diagnostic. So histopathology and microbiology is must. So this is one of the appearance of tuberculosis. When you do 22 or 21 equal efficacy, 3 to 4 passes, specimen handling is very important. You know, it is not only the cytology. You should send cytology for smear and cell block. Always take a cell block. Suppose it is a malignancy, then you will be searching for cell block, and when you want to do a NGS studies and other things. So cell block must be maintained, AFB smear, and then CBNAT. You must obtain a sample for CBNAT, and now there are studies which I'll tell you also, must rinse the needle because they have seen the yield is better when you rinse the needle with saline and rather than just taking the histopathological sample. And then mycobacterium culture, MGIT. So this is the minimal you must send when you are suspecting. So diagnosis of TB on EBUS is cytology plus microbiology, not the granuloma alone, because granuloma can sometimes misguide you. Many times in lymphoma also in the periphery you may see granuloma. So this is the kind of granuloma where you see the caseation necrosis and there are epithelioid histiocytes, and also you see on the side there are lymphocytes also. And AFB if you get, not in every, because a paucibacillary disease, 15-20% will show if you really look for AFB, but every sample must be sent for AFB. So how will you make a diagnosis? KZ10 granuloma plus minus AFB, gene expert positive, culture positive, any of these. So granuloma without microbiology, you know, this is sometimes TB likely in endemic area, but not very certain. Most of the people make diagnosis in the fourth one, but exclude sarcoidosis when you have granuloma without microbiological proof. And many a times we started on ATT and later on we realized that it was, because nothing came positive, that it was sarcoid. Fungal disease, particularly in patient who's immunocompromised, you must think of. False negative, you could get a fibrotic or calcified nodes, even if it is active. Inadequate sampling. Drug-resistant TB, if you are thinking, I don't know whether you know or not, we nowadays in Delhi it is available, XDR Gene Expert. So where you can send the sample, same sample for where you will get a capreomycin, amikacin, ethionamide, and quinolones, which you can send like the normal Gene Expert rifampicin. Similarly, XDR Gene Expert is available, which you can send all these. So this is a patient, again, classical patients, you see hypoattenuated, and this patient had a heterogeneous lymph node with some amount of necrosis, and the TBNA was done, and it was Gene Expert was detected in high, so you were very sure, and there was no resistance, so the regular ATT was advised. This is the kind of reporting you get. This is although from a cervical node, XDR, where all these can be tested particularly. Now you need not wait for a few weeks, and you can get the result in 2 days and you are ready with the drugs. This is another patient. Again, you see there is a necrosis, but this patient had pus was aspirated. Many a times you will aspirate pus from these, and then when the treatment was given, it all resolved. This is another patient where you see these. These are the kind of appearance you see in tuberculosis, and there was a granuloma. Another kind of appearance which you see in tuberculosis. In our country, there are many like this. So what does the literature say? It is somewhat similar. This is a study from Australian, and they sent all the samples, and they confirmed TB in 25% of these lymph nodes. There it is not that a common disease. Specificity was 100% and sensitivity 92%. All India Institute published a study where they took all the TB samples, and they found 4R was the commonest station where they found the tuberculosis positive, and the diagnostic yield was 74.3%. Minor complication, and they also said that this is a very, very safe procedure. Dr. Chajad from Mumbai published on the MDR TB patients. He took out all his retrospective study where he took out all these patients. They had sent the samples for everything, and they found that 11 patients out of 56, he had a MDR TB in these patients. So this is also there if one is looking for. Then this is a study where they said that when you do a needle rinsing of the fluid, always after every pass, you made a slide, then do a saline rinsing and keep on collecting. And they found the yield was better, and they could increase the positivity by sending the needle rinsing of the fluid. There is a study done in children also where they combined EBUS and EUS, and this was a study published last year in Lung India, that 50 children, 20 were diagnosed with mediastinal TB, mean age about 11 to overall 76% when EBUS and EUS were combined in children. So this is the modality. What I'm trying to say, EBUS combined with EUS in children is probably you will get a better yield. And they had very good sensitivity and good specificity. And pretty safety profile as far as of the EBUS is concerned, it is very safe. So practical algorithm for mediastinal TB would be that after you have history, physical, CT thorax or MRI, EBUS TBNA, send for cytology, cell block, biopsy if you get it. Send for gene expert plus MGT culture. If TB is confirmed, as I said, you can send for them for ATT. So just to summarize, mediastinal lymph node, think TB in our country. Of course, it is one of the, still the common disease, confirmed with tissue. And then PET CT is suggestive but not diagnostic. So don't waste money on the PET CT. EBUS TBNA is the first line diagnostic modality, minimal invasive, outpatient, safe, diagnostic yield 70 to 90%. You require cytology plus microbiology, not the granuloma alone is insufficient. So just don't make slide, must send all these sample, always exclude mimic, sarcoid, lymphoma, fungal disease. Optimize sampling, always send EBUS sample for cytology, cell block, AFB smear, culture with MGIT, and gene expert for MTB and rifampicin or ultra, or if it is resistant, XTR gene expert. Minimum 3 to 6 passes per node. Needle rinse fluid enhances the molecular detection, so you must send the needle rinse fluid. Culture remains essential, avoids empirical ATT whenever possible, because even today, 70 to 80% of mediastinal TB is still treated empirically. And isolated mediastinal lymph node disease, EBUS TBNA, microbiological confirmation and the target. That's the algorithm today for treating mediastinal TB or approach to mediastinal TB. Thank you very much.
Sir, I'm just curious, do you use the scope by esophagus route also? You don't?
Not that often. Because
It is not your choice.
as a pulmonologist, EBUS will be my choice. Yeah, but after listening to you, I think it is essential to train yourself in EUS as well. Because I think, you know, in patients like COPD, patients with respiratory distress, EUS is a much easier procedure than going into the trachea.
See, this issue is debated since, and you are a senior person and coming from your authority, it will matter. I personally believe because the last case that I did was significant distress. And you should have a positional stand at that if patient is having borderline respiratory distress, defining whatever way you will not attempt to put in any scope into the bronchus. You should have your indication of bronchoscopy.
I agree with you. You know, the other thing is, like Dr. Virotam was saying, probably when you go through the esophagus only, you don't require that much of sedation. So that's another COPD person who is very prone to get a respiratory depression. So you would avoid this kind of distress to those. I think this is just a process. Most of these senior people have started doing EUS as well, and as people like you who train a lot of people, EUS will also be part of. I think we can go to the stomach, but I don't think you will be able to enter art.
No, I agree with that. That is no debate.
No.
But what I am saying is,
I think I agree with you. EUS is that way in certain nodes. Probably 7, it is one of the best modality. If you have a big 7, then probably that would be.
means because probably funds in your specialty, a facility like you is no problem. So you should probably encourage and make it a protocol that mediastinal EUS with a big scope should be also part of the curriculum of training for pulmonologists.
I agree with you.
You agree with? Let us try. Let us move to the place where pulmonologists can use a bigger scope, limited to use from esophagus. Okay, thank you.
Now for the next lecture, I would like to invite Dr. Akansha Chawla ma'am, who is a senior consultant in Department of Respiratory Medicine, Critical Care and Sleep Medicine at Indraprasth Apollo Hospital, Delhi, to speak on the topic needles, complications, and troubleshooting in EBUS.
Before I speak, I would like to make one course correction of my demonstration. In my demonstration, I was demonstrating right pulmonary aorta, and in my mind, I was saying this is left inferior pulmonary vein, but they're actually right pulmonary veins in the demonstration. So I want to correct myself. And I especially invite Dr. Chawla, and I'm thankful to because she was kind enough to agree immediately on first response, but she's most welcome. And again, Dr. Chawla both. So it is important that we enhance the skills in this field in the country, and the responsibilities lies on the younger and the older generations. Thank you, Kansha.
Thank you. Good morning. So I think we've talked a lot about techniques. Let's just look at the needles that we use, the complications and how to handle them. I would like to stress here that EBUS, I think EUS as well as Dr. Malay sir and Dr. Virotam sir have demonstrated today are very safe procedures. So the complications are less once they are in the expert hands. It is a minimally invasive access to mediastinal nodes, hilar nodes. It gives you a real-time ultrasound guidance. Of course, it is one of the main diagnostic modalities for your lung cancer diagnosis, for staging, for granulomatous diseases, and for selected benign and malignant adenopathy workup. Again, I would say it is the least invasive and gives you a high yield. So let's look at the needles first. There are various needles that are available, ranging from different gauze, like 19, 21, 22. The commonly used one is 22, 25 is not available. So before we look at the needles further, let's understand the parts. So if you look at this image, this is an Olympus 22 gauge needle, and you know this is where your stylet is. So when you insert a needle, you actually first look at the stylet, you remove it, first clean the channel, remove it, and this is where you put in your suction. This is the aspiration port, just where your stylet also goes in. Then this is the needle slider. Then this is the needle adjuster, which has a lever. So this basically helps you to define the depth. So you can measure the depth, predefine the depth, and then accordingly decide how much you want to penetrate your node. Then there is a rotatable sheath adjuster knob, which you use at the beginning when you're adjusting your needle, when you look at the sheath and you decide that your needle is in position to go. And then of course this is a bronchoscope adapter, which fits on your EBUS scope and fixes your needle. So these are the basic parts of a EBUS needle. Now, you know, whenever you're doing a procedure, you should have a checklist. Always be prepared. You should know what stations, look at your scans well, understand the sizes, look if the node is very necrotic or not, what part of the node do you want to. Of course, this changes when you put in your scope and see it in real-time ultrasound. But you need to remember that you have a preparedness before you go. Always map your vessels, because there is always, although very minimally invasive, but there can be a risk of bleeding. And you know, you should have a specimen plan. Like Dr. Chawla sir just mentioned, that you must send a specific set of samples, and that should always be planned before you're doing your procedure. Now, like I said, 22 gauge needle, this is the commonest one that we also use. It has an easy node penetration, it has gives you a reliable cytology and cell block, and it's most commonly used needle. 21 gauge, it has a slightly larger lumen, and although you know the yield has not been seen very superior as compared to the 22 gauge. Then of course 19 gauge, you know, when you intend more tissue or more histology fragments, but again on comparison not very superior in yield. So I think that is the reason why most commonly 22 gauge needle is the one that is used. 25 is not available, and I haven't seen it. When you have very firm fibrotic tissues or fibrotic nodes or nodes at acute angles, then the smaller the gauge of the needle, more flexible will be your system. So I think 22 gauge becomes again a most commonly used. It's very comfortable once you get used to it. Now, how many passes do you take with these needles? If you have a rapid on-site examination available, if you have your pathologist on board on-site, then you know once you have the adequate sample, you can just simply stop sampling. But without rows, minimum 3 to 4 passes at each target node. And you know, when you have a more necrotic center in your node, avoid repeated sampling from the necrotic center, because you know this one decreases your yield and Second, it makes the patient more prone to infection risks. So again, let's just look at the needles. This is the Olympus EBUS needle with different gauzes, 21, 22. This is the close-up view of the 22 gun and 21 gauge needle, and you can see that there is the ecogenic markings that you can see through the just above the tip. The tip is beveled. Then this is a 19 gauge needle, which is designed for a larger core and histological sampling. The 25 gauge needle. Then there are other needles that are available, like the Boston Scientific Expert needle. This is the image of the Expert needle. Now this has an ergonomic design and a visible echogenic pattern for precise needling. They're much more advanced needles. Then the Cook needles. Cook needles also come in various designs like the EcoTrip Ultra, the Pro Core FNB designs, the Core Trap for more improved tissue harvest. And of course they have an adjustable sheath and an ergonomic handle for procedural stability. I think this is something that is available across needles as a feature so as to make your EBUS sampling easy. Now I'm just going to talk very briefly, because this is going to be covered in detail, about the EBUS guided mediastinal cryobiopsy. So this is an adjunct to the technique of EBUS TBNA. When you want to obtain larger architecturally preserved tissue samples from mediastinal or your hilar nodes. Now this has been very widely used for lymphoma subtyping, for your granulomatous diseases like sarcoid, when your EBUS has been non-diagnostic, and of course for immunohistochemistry and molecular testing. Now you can see here that in the first view, the bronchial view of the mediastinal space, there's a puncture site. And now you can see that the cryoprobe is entering, if you can appreciate on this picture, under direct visualization. Then you see the EBUS view of the probe entering. And you can see that the tissue has been taken en bloc over here, if you can appreciate, which has been removed along with the probe. So this is the basic procedure, would be discussed in detail. It's usually performed under deep sedation or general anesthesia, and it's often done as a combined approach. So you do the TBNA first, and then you do cryobiopsy if you require more tissue. It's an acceptably safe procedure. Very rarely you would have complications of mild to moderate bleeding. And remember that it is not a replacement for your EBUS TBNA, but when you require more tissue sample, so then, and if you have the availability, then this becomes an adjunct, it adds on. So it should be done in combination. After the needles, let's look at the complications. Again, I would like to emphasize it's a safe procedure and it's minimally invasive, but then you can encounter a few complications like minor bleeding at the puncture site, transient cough, bronchospasm, hypoxemia. Let's go ahead and look at the complications one by one. So bleeding. Now if you have a patient where you suspect bleeding or there is a risk, first of all, if your patients are on antithrombotics, always have an antithrombotic plan. Know when you need to discontinue, and of course when to restart. Never ever force a needle. Don't, it's a rule for any procedure, for any scope. Never force in a scope, never ram through, never forcefully enter your needles through the nodes, because this can not only lead to bleeding, it can lead to trauma, it can damage your scope as well. And of course, always check with the Doppler. There is a Doppler available on the system, so you must check with the Doppler. This prevents you from entering through the vessels, because a lot of times these nodes are a little vascular. So that is okay. Minor bleeding is generally self-limiting, doesn't have much problem. However, if you do have bleeding, what would you do? How would you manage it? Stop sampling immediately. You should stop the procedure and suction and have the view. You should, once you're able to view your segments, once you're able to see, usually the bleeding is minimal and is self-limiting. You can wedge your bronchoscope to cause tamponade, and once this is done, if you can achieve stopping the bleeding, great. Otherwise, you can also, this is easy, you can instill cold saline and topical vasoconstrictor if your patient's underlying condition allows. If the bleeding is persistent, then maybe a balloon tamponade may be needed, very, very rarely. And very rarely, fortunately, I haven't seen that you have to escalate it to convert it to a rigid bronchoscopy or call an intervention radiologist or maybe a surgeon, but never refrain from taking help if needed. Then, like I said, your antithrombotic plan should always be in place. There is always assess for thrombotic risks. If your patient are on specific anticoagulants, you should know when to stop and when to restart accordingly. I think this everybody already knows. Then the other complication that we look at is hypoxemia, bronchospasm, and events related to sedation. So your patient might be desaturating, there could be a rising EtCO2, patient might have wheeze, maybe agitated, there could be an airway obstruction by the scope. So again, you pause, stop, and you must all know how to do a jaw thrust, because this really helps when your patient is desaturating. Suction the secretions, clear the airway, reduce the sedation, and if there's a bronchospasm, give an inhaled bronchodilator. If you have a patient, a lot of these patients have COPD, so give a bronchodilator pre-procedure, because that really helps. And sometimes even IV corticosteroid when needed. And if you have a patient who needs airway support, do not refrain from doing it. A lot of times there are obese patients, and in those cases, sometimes you have to protect an airway. Often LMA is enough, but if needed, you can do an endotracheal intubation as well. And of course, the least time you keep in these patients, plan the stations, take quick passes, your procedure's duration is going to be lesser, so the complications would be lesser. Very, very rarely pneumothorax and pneumomediastinum. So the typical signs and symptoms of a pneumothorax or a pneumomediastinum may be seen. Patient may have sudden desaturation, hypotension. Workup would be, easiest would be if you have a bedside ultrasound to quickly see, but if not, then maybe a chest x-ray. And management, usually these pneumothoraces are small, so when the patient is stable, oxygen is enough, and you can observe the patient. If there's a large pneumothorax, you need to insert in an ICD. Now, although very, very rare again, the infectious complications, patient would have typical features ranging from fever, may have a pneumonia, mediastinitis, pericarditis, sepsis, and abscesses. So this generally is seen mostly in patients who have cystic lesions or who have necrotic lesions. When you repeatedly, sample to the necrotic center. Again, not that oftenly seen, and patient may have, there could be another risk factor, like there is an associated contamination, or the patient is an immunocompromised host. So, these would lead to more infection, because necrotic nodes we often come across, and we do take repeated samples, but this is a very specific subset. And what do? Do you give prophylactic antibiotics? So the answer is no. But if the cystic lesions are there, then in those cases, you might consider prophylactic antibiotics. And if you have a patient with fever and chest pain within days or weeks after EBUS, clinical history and clinical examination always remain. But like you do a workup for any other fever, you go ahead with the same. CT chest, a repeat may be needed. And if you have any cardiac issues, you may need to do a cardiac workup with ECG and echo. Depending upon the underlying condition, you may have to start with broad spectrum antibiotics. And drainage may be needed when there is an abscess or a pericardium. Then there can be complications related to the equipment as well. For example, you can have a needle tip breakage. So when does this happen? When you, like I said, never forcefully try and put in the needle. There can be an acute angle at which you've entered. Then you can strike the cartilage ring, and there can be a repeated heart puncture. How do you prevent it? You withdraw and you realign if there's a resistance. If you're coming across a resistance, you can also choose an alternate procedure point and avoid ramming, avoid forcing. If it does happen, if you do see, what do you do? Stabilize the scope position, do not panic, inspect the airway for fragments. You can remove your EBUS scope, go in with a normal bronchoscope, inspect, and if you feel that you can remove, you can try it with the forceps or with the basket. If not seen, you can do a chest x-ray or a CT to localize where your fragment has gone and got lodged. I have not seen it, but if it does require a surgical intervention or a surgical procedure, then you may involve the specialist as needed. And this was a case, was published by Dr. Saurabh Pahuja. After taking the second pass, they saw this fragment lodged. So then they took out the EBUS scope, they went in with the normal bronchoscope, and they took it out with the alligator forceps. So it can be managed if you notice the complication and if you're able to, understand that this has occurred. It's usually not very difficult and generally doesn't happen, but if it does, it can be taken out with your forceps. Then this was a case of a smoker with right paratracheal lymph node. suspected lung cancer. Now, this patient was on aspirin because he had a history of coronary artery disease. So, after the second needle pass, there was brisk oozing from the puncture side and patient's saturation dropped. So again, immediately the procedure was stopped, and by suctioning the field was cleared, cold saline was instilled, and with proper oxygenation, the bleeding settled within 2 to 3 minutes. So, stopping the bleeding, first always, like I said, always have an antithrombotic plan. If you cannot stop, usually the bleeding with aspirin is not much of an issue, and you can wedge the scope, you can instill cold saline, and usually minor bleedings generally stop. Then another case of a patient who became hypoxemic, sudden desaturation. Like I said, always remember jaw thrust, oxygenate your patient, check for bronchospasm, look at the reason why the patient desaturated, and accordingly manage. So, just to summarize, EBUS TBN is a low-risk, high-yield procedure. Needle selection should be indication-driven. Adequate technique improves yield more than the needle choice. Complications are uncommon and usually manageable. Bleeding management is a stepwise and endoscoping in most cases. Stop sampling, suction, scope wedge, cold saline may or may not need a topical vasoconstrictor. And it's a low bleeding risk procedure in patients even on antithrombotics when planned properly. Infective complications, though rare, must not be missed. EBUS guided mediastinal cryobiopsy is an emerging adjunct, not a replacement, and overall success depends upon planning and troubleshooting than the technology alone. So in EBUS, good outcomes depend less on the needle we choose and more on how thoughtfully we use it and how prepared we are when things don't go as planned. Thank you.
Thank you, Dr. Akansh, very simplified, very informative
Thank you, sir.
talk. I have only one question. You have mentioned this EBUS cryobiopsy. So when you decide that my patient needs this EBUS cryobiopsy, before procedure, during procedure, or after doing this FNAC? Because it's difficult, because it's not needed in all patients. When you take the decision that my patient is also need the cryobiopsy?
Sir, I believe when you have to do a procedure like a cryobiopsy, if you plan and if you think that your patient is going to require more tissue sampling, pre-procedure is always better. But sometimes in cryobiopsy cases, it is planned sometimes during the procedure as well. But preparedness for it has to be there pre-planned and pre-procedure. Otherwise, it's not that.
I think boss has given the answer to this question, Dr. Chawla. Because it's not possible to do in all patients. So when
You
to
don't need it in
decide
all
that my
patients.
patient
Yes.
needs the cryobiopsy as well?
Sometimes what happens when you are doing EBUS and there is no sample is coming out, the dry slides, you can say FNAC, then at that moment you require that this patient is having hard lymph node, patient may have lymphoma, or previously you have done this EBUS and inadequate tissue, or there's only granulomatous tissue and doubtful lymphoma or sarcoidosis, then at that time you required larger biopsy tissues.
I
Dr. Karan?
disagree with you.
Dr.
I
Karan,
disagree
your
with all.
statement,
Your-
please.
Sorry, I disagree with you. One reason I disagree is that we do EUS and we have hardly ever needed any time a cryobiopsy ever. So what Dr. Singh says has a reason. It is cryobiopsy is more as a fashion or a passion of individuals or rather than the need of the patient or a show off, whatever you say.
So very well said. So you see, a large part of what we do, EBUS or EUS, is operator dependent. An experienced operator would be, we've been doing EBUS, EUS is being done, and yields have been good. Cryobiopsy has come as an adjunctive modality. It gives you larger tissue, available talk of data. 2 meta-analyses have been done comparing yield of EBUS TBNA versus cryobiopsy. There's a 10% increment in yield. Now the question is, who are the ones in whom we also face non-diagnostic EBUS sometimes? So there was a good paper from Hyderabad in which when they are doing EBUS or EUS, during EBUS they are doing rapid on-site evaluation. In those patients in whom ROSE was negative, they did cryobiopsy and found that 60% of ROSE negative, you get an additional diagnosis. So if you have an on-site pathologist, second thing, in lung cancer, data shows that there is no increment in yield. If your pre-procedure diagnosis is a paratracheal mass, lung cancer, we've got excellent yield of lung cancer with a needle alone. So if it's a benign condition, as Dr. Tomar also said, that there is no tissue which is coming. So I think the decision, it's not right that blindly go everyone with cryobiopsy. I think case by case, and I think it's very difficult to do it beforehand also. So during the procedure, sometimes if you are not getting, then you can consider.
Sir, I'm just going to conclude. Your question was whether pre or during or post
Because
procedure. Sir, I think
you
it's
have to
a
decide that I should go for the cryobiopsy or not. What is my learning and by what I have learned from the all seniors, then whenever there is a thought process that we are dealing with sarcoid or it is lymphoma, then only we have to do the cryobiopsy. It is more of lymphoma because you can't make the diagnosis of a lymphoma by FNAG only. You need the larger tissue. That is the absolute indication for doing this.
Thank you.
I think
Thank
we
you
can
very much.
continue in the breakfast. Please, small tea session. And the request is that tea session is going to be really short because we have to continue. We are already late.
Thank you so much, Dr. Akansha Chawla, ma'am. Now it's time for a short tea break. Tea is served on first floor. The next session will be continued after 15 minutes. Kindly be present at 11:25.
Now it's time for our lecture session.
For chairpersons, I would like to invite Dr. Rajesh Chawla sir to please take over the dais. And also I would like to invite Dr. Ayush Jain sir, renowned pulmonologist, currently running his clinic named Pulmocare Clinic in Meerut and also affiliated with Lokpriya Hospital, Meerut.
For the lecture session, I would like to call Dr. Karan Madan sir, Professor and Department of Pulmonology and Critical Care, AIMS, Delhi. Please give a big round of applause.
Thank you. Thank you, Dr. Tomar, Dr. Malay, the entire team for this kind invitation. I would be speaking upon one of the important indications of EBUS TBNA, that is lung cancer, and how you need to take certain things in mind when you approach lung cancer diagnosis using EBUS TBNA. You had a previous talk in which you heard about the technique of EBUS TBNA, how do you do EBUS TBNA, and I think if you talk about common indications, lung cancer, TB, and sarcoidosis would be the three most common indications of EBUS TBNA you would encounter in your practice. And so let us see what things you need to keep in mind. So once you talk about lung cancer, you see the clinico-radiological profile to begin with. That's the first most important step. And then you need to take a sample for confirmatory diagnosis. And whenever feasible, diagnosis and staging of lung cancer should be done concurrently, because just getting a diagnosis that, okay, I've got a tissue and this is lung cancer is probably not enough in most of the scenarios. And also you need to target the biopsy site which would yield the maximum stage. For example, you have, say, a small lung nodule, and then you've got, say, a pleural effusion. Now, a pleural effusion, just upstages the disease significantly higher. So even if you biopsied the lung nodule and told that it is lung cancer, this would not probably be enough for initiating treatment, because the effusion may be malignant or non-malignant, because there are multiple causes of effusion, say, in lung cancer. Say you had an isolated adrenal nodule and a lung nodule. The adrenal being positive would be a metastatic disease. So I think these are very important. Once you consider lung cancer diagnosis, just don't be fixated on the lung parenchyma and think beyond. That is the bottom line. So if you talk about the guidelines, they say that you use the least invasive technique and you get the adequate tissue, which gives you a molecular analysis and all the ancillary tests that you need to perform on the tissue. The most important question that a pulmonologist would face when approaching a lung cancer diagnosis is what modality to use. Because you will have an abnormality in the chest. This is a big thoracic cavity. It's not just the lungs. You have the lungs, you have mediastinum, you have pleura, and you have various compartments, and you want to see, because the lesion can be either in the inner half of the lung or it can be very close to the periphery. So it can be a peripheral lung nodule, it can be a central mass. So how do you choose? So conventionally, if you have a lesion which is located centrally or peribronchially, thereby meaning something in the lumen of the airway, close to the lumen of the airway, something which is paratracheal, peribronchial, you have signs on the X-ray showing like a collapse or an endobronchial lesion or endobronchial symptoms like hemoptysis or wheezing or unilateral wheezing. These would indicate that the bronchus is kind of involved, and an airway-centered approach is going to give you the diagnosis. In contrast to this image on the right, where you see that it's a lesion which is very, very close to the periphery. It is abutting the chest wall. In present day, you can approach these lesions also bronchoscopically. There are certain tools. But I think something which is very close to the chest wall is better handled by an approach which may be percutaneous or from the outside. So these are the things you need to consider. This does not mean lung cancer is equal to bronchoscopy or lung cancer is equal to EBUS. It is you understand the whole picture and then you choose this would be the best modality for getting the diagnosis and stage in this patient. So once you talk about bronchoscopic modalities, you may have a conventional bronchoscopic modality, or second thing is the broader term for this is endosonographic modality, and this is very good. We are in this hall in which we have a gastroenterology and pulmonology together, And this kind of, sync is not common at many places because pulmonologists and gastroenterologists usually operate in, two different directions. So if you have an approach where you can choose that who can do this procedure better, that is also very, very important. So conventional bronchoscopy would mean, getting a biopsy like an endobronchial biopsy, brushing, lavage or needle aspiration. And once we talk about endobronchial ultrasound, we are mostly talking about in this meeting about EBUS TBNA or linear EBUS, thereby meaning you have a probe by which you can, get a needle aspiration from the peribronchial or peritracheal tissues. But you also have a modality, you see this image on the right, called as radial EBUS, which gives you a 360-degree view of the distal lung parenchyma by a rotating probe. And this is useful for sampling the lung parenchymal lesions. Now, as I have told, this is not just about diagnosis. You also need to stage the disease. Stage means whenever we talk about staging, it is the T and M staging, that what is the tumor stage, what is the node stage, and what is the metastatic stage. Because incorrect T and M classification will have a lot of impact on the patient outcome. If you have a mediastinum which is positive for lung cancer and you take the patient for upfront surgery and you've not detected that disease, it will lead to a bad outcome. Or second thing is, if you went by a PET scan and PET scan showed you some uptake in the nodes and you say that this is not operable and that node was indeed not positive, then you have missed an opportunity for the surgery. So these are the things which are important in the context of staging. So how do you initially stage? The first modality which is recommended for lung cancer diagnosis staging is a CT scan. It is not a PET scan. A CT scan including adrenal and the liver should be your first investigation, and don't use PET scan blindly. And important thing is that identification of metastasis on a PET scan does not preclude the requirement for histological assessment, because the sensitivity of the PET scan also reaches close to 80%. It is not excellent for diagnosis of mediastinal metastasis. You cannot take PET CT scan findings in isolation. So let us come to the issue is how do you integrate EBUS TBNA in the context of lung cancer diagnosis and staging. This image actually summarizes the combined sensitivity and specificity for mediastinal staging in the context of lung cancer. If you will see, the PET scan sensitivity is quite poor, and if you see EBUS TBNA sensitivity is close to 90%. If you integrate with an endoscopic assessment also, a complete mediastinal staging, then the sensitivity reaches close to 91%, and it is a very, very specific modality. Specificity is, 100%. Now talking about the accessible lymph node stations by EBUS, you may have had this discussion in the previous slide, but I will again repeat it. That EBUS gives you an access of all the, the central stations which are in the paratracheal location and the centrally located node, but importantly, once you branch out into the bronchi, the hilar, interlobar stations and the pulmonary stations are accessed by the EBUS TBNA. And the esophageal approach gives you an access to the central lymph nodes, and particularly the left-sided lymph nodes, and a large paratracheal lymph nodes on the right side can also be sometimes accessed using EUS FNA. This is probably the most important slide of the presentation, that how do you, name the stations in the context of lung cancer staging. So say you have a lesion in the lung on either or right or the left side. So in this case, we are, taking the left side as the primary. So there is the lesion nodule or the mass. So all these nodes are located. So what is basically an N1 node, what is N2 node, and what is N3 node? So N1 node will be a node which is starting from, the hilar location and into the lung parenchyma onwards. So this station 10 is the hilar station. 10 onwards, 10, 11, 12, 13, 14, these are the N1 nodes. The N2 nodes are the mediastinal nodes. So this thereby meaning the paratracheal nodes and the subcarinal node. This is an N2 node, and a contralateral lymph node is an N3 lymph node. So this is very important, because the oncologists really want this information when they want to treat a patient. They want that what is the end stage, and then because their decision of upfront surgery, neoadjuvant surgery, what they want to offer the patient all changes based on this. So how do you go about sampling? We will talk.
So basically there is a recent revision of the TNM staging. Not much has changed in TNM, but they have divided the N2 station into N2A and N2B, thereby meaning that if it's a multi-station involvement, that is termed as an N2B, and then otherwise the other things have not changed. How do you start is that you have to systematically stage each lymph node station. So look at your CT scan. In this case, the primary was on the left side. So if you are doing mediastinal staging, which nodes will you stage first? The highest stage you will stage first. So you will screen the right-sided node first, because if a right-sided node is positive, that will be an N3 node. So move from N3, then move to N1, N2, and then move to N1. This is the systematic approach you need to follow once you're doing lung cancer staging. Just going blindly and sampling one node is not enough. That would not be the ideal staging procedure. Station 10. Can anyone tell me what is station 10? If anyone who has done EBUS TBNA here. So,
below the azygous vein, when you enter, just touching the starting of upper lobe, and that is main difference is you have to differentiate between 7 and 10. On the left side, again, it's just the left upper lobe, and just below the pulmonary artery is 10.
yes. So this is one of the most infrequently screened and sampled node by pulmonologists. You know, we usually would see the paratracheal nodes, we will see the interlobar nodes, the 11 node, but we would sometimes miss the station 10. So guidelines also say that it is technically, you know, challenging to sample, but also screen for station 10 nodes once you are doing EBUS TBNA. And if you know the anatomy, then you can, you know, sample these nodes also. The other important question is N3 nodes. So N3 nodes, I've talked to pulmonologists, they also sometimes routinely don't do it. This means say it was a node on the, in this case the lesion was on the left side. So whether you actually need to do N3 node sampling in all patients. So there was this recent paper which I was going through. Authors have recommended in this case that if your PET scan does not show nodes on the opposite side, or it shows you small node which is less than 5 millimeter, then probably you can avoid a contralateral sampling, but otherwise it is always better to screen the opposite side, because as soon as it becomes N3, the stage dramatically jumps up and surgery, you know, the chances of surgery go down dramatically. So now, how do you integrate EBUS TBNA into your practice? Now, this was a study which showed that, you know, if you do by the conventional approach, people and patients undergo bronchoscopy, CT guided biopsy, a diagnosis of lung cancer comes. But the staging or an EBUS is done later. And during all this waiting, decision making, the stage of the patient can go up. So this was a study which was done in UK, very important study, that if you use an upfront EBUS centered approach for lung cancer diagnosis, what impact does it have as compared to the conventional strategy, say doing a peripheral biopsy or a bronchoscopy followed by EBUS. So the authors found that the time to treatment decision when using an EBUS centered approach was dramatically shortened, and number of investigations per patient were reduced, and, you know, patients were diagnosed with and staged in the one go with one modality. So if you are having a central involvement, choosing an EBUS centered approach may be more wiser, because on one go you will get diagnosis, stage, decision done, surgery, not surgery. That is important. So all EBUS samples can be used for all molecular testing. If they are taken well, you can take samples for core tissue, and those can be used for sampling. Some things which you need to take care when taking these samples. This was a guideline on sample preparation aspects during EBUS TBNA, and the key messages I will speak. So at least you need 3 passes for optimal performance. Needle, gauge, mini forceps, suction, sedation does not have impact on yield. Rapid on-site evaluation has not been shown to consistently improve the yield in lung cancer diagnosis. And molecular analysis can be formed on majority of samples. And there does not appear to be any superior method of sample preparation. You know, cell blocks should be prepared, and, you know, samples should be taken on slides. The comment on mediastinal cryobiopsy I already made in the comment previously, that although the increment in the yield by cryobiopsy is 10% as compared to EBUS TBNA overall, but this was not seen in the context of lung cancer. In lung cancer, EBUS TBNA alone is good enough for diagnosis. You do not need to routinely integrate cryobiopsy, and cryobiopsy cannot be used for mediastinal staging in that, systematic manner. And this study also I spoke about that if you use ROS negative patients who have negative pathology on site, maybe then you can consider cryobiopsy in selected patients. So this is a paper, this is an Indian paper, the guidelines on EBUS TBNA, it was also mentioned in the previous presentation. This essentially summarizes all the useful points for EBUS TBNA once you are learning, so this is a useful paper to go through. I'll just go through quickly in 2 minutes through 1 or 2 case scenarios. So this is a patient which comes to you with a left upper lobe small nodule. Now this patient, obviously understandably bronchoscopy was normal, CT guided biopsy turned out to be inconclusive. And PET CT actually shows you small nodes, and in this case, this turns out to be lung cancer. This is a common scenario that even with a small nodule, the mediastinum may be positive. And this is one more thing which which happens commonly and you want to see. Right upper lobe lesion, right paratracheal node, no nodes on the opposite side. Now, once we are doing EBUS TBNA, you find a left paratracheal node which is not seen on the CT scan or the PET scan. And this is positive. So the disease become N2 to N3 and the operability goes away. So I think this is also very important that whenever you are thinking of surgery, always screen the N3 nodes, and this will be useful. Another thing is necrotic nodes in our setting are not always TB, and necrotic nodes can very frequently turn out to be lung cancer. So essentially I have summarized all the indications, how do you and when do you perform EBUS TBNA, central lesion, and a non-diagnostic situation, normal flexible bronchoscopy. And also this is very importantly for restaging of lung cancer, because many a time you will get referral, patient has been treated for lung cancer, now oncologists want more tissue for progression. So so this is also very important. And lastly, a small mention on radial EBUS. Radial EBUS is that rotating probe which can be used to go into the peripheral pulmonary lesions, and this is very useful if you have something called as a bronchus sign. Bronchus sign means if you can see a leading bronchus into a nodule, in that case the yield of radial EBUS guided biopsy increases significantly. So summarizing, I think the initial procedure you have to choose based on careful assessment of CT. Read your CT scan well, decide which is the highest stage, then choose the modality for diagnosis. Otherwise, you'll choose a bronchoscopic modality and then end up doing more tests for getting staging information. And for optimal specimen acquisition, choose the right site, also take right quantity samples and choose the right method. Thank you.
Thank you, Dr. Karan. Any questions from the audience?
We have to send more than one sample to label it, but what other we can do to label it is malignant or not?
So it's not very usual to find an effusion with a very, very small nodule. Usually effusion is seen in the setting in which the disease burden is also high, in which the parenchymal disease burden is high. But you may have a situation in pleural effusion may be there and the lung lesion seems operable and the mediastinum seems negative. You do pleural fluid cytology as recommended, 1 to ideally 3 cytologies, but I think if that's a doubt still remains, a thoracoscopic pleural biopsy should be offered. Because in that case, the effusion decision becomes very, very important for further management plan of the patient. Because effusion in lung cancer can be due to pulmonary embolism, hypoalbuminemia, multiple conditions. Tuberculous pleural effusion has been reported in the setting of concurrent lung cancer. So we've had patients in which there is a concurrent lung cancer, effusion, thoracoscopic pleural biopsy shows classical granulomas, and there is a tuberculous pleural effusion in lung cancer. So if isolated effusion, you have to chase the effusion.
It will change the stage of the disease.
Yes.
I think one of the most important thing is lung cancer even today, the curative or a better survival is with the surgery. And nowadays, many times they would give chemo or immunotherapy and downstage, and then probably patient become operable. So that's also done. So in such cases, do you repeat the EBUS? Have you done this kind of thing? Yes. And then probably the node which was positive has become negative, and then they go ahead.
Yes. So say the N2 disease positive, they do chemo, they do the medical oncology, gives their treatment, and then maybe refer back sometimes to us that we want a restaging. So I think those things are increasing more and more. You know, if the patient initially responds to EGFR TKIs and then again has a PET scan which shows disease possibility, you will get referral. We need sample for, you know, mutation analysis and everything. So I think EBUS in that way is required.
You know, the other thing he highlighted very important is that if you don't see on a PET or CT, but when you're doing a EBUS, you must screen all the nodes, starting from the N3, then go to the N2 and all the N1s. It doesn't take more than 10 minutes, but because many a times, like he showed the case, it was not there in the CT, but it was positive, and that's very, very important.
Yes, it's very important. What was the size of that you have sampled? So less than 1 centimeter, I think.
Yes, it was almost a centimeter or less. It was a
But
left paratracheal.
2025 study you mentioned that if it is less than 5 we can avoid.
Yes.
Okay. Yes, that is important.
But I think if you are having a PET positivity, PET scan is lighting up. Definitely try to, if it's in your range of sampling, try to sample it.
You know,
one more thing.
Dr. Karan, leave aside this. I mean, I want to ask a question. Which are these nodes? You know, nowadays, because EBUS is available, people are just sampling if the node is visible. So when you should not sample, EBUS is not required. Can you tell the sizes, or every patient who has lymph nodes in the chest and you should do an EBUS?
In the setting of lung cancer or generally?
No, not lung cancer. Lung cancer, of course, you need to, but I'm talking just generally.
This is a very, very important comment, because, you know, in general pulmonology, if then you have to, because what is happening is we sometimes are not integrating the clinical scenario. So you have a patient with ILD. CT shows classical NSIP pattern. The history is like an interstitial lung disease, and you have few nodes which are expected. Even centimeter size node or sub-centimeter node which are expected, say you have a connective tissue disease, SLE. So I think it's not that we have to chase each and every node without integrating the clinical scenario. If your clinical scenario substantiates a diagnosis, you are not considering lung cancer, TB, infection, sarcoidosis, any other condition. Your clinico-radiological profile is going with a condition and there is small mediastinal lymphadenopathy present. Why do you want to chase it? And that reduces the diagnostic yield of the procedure. You are getting non-diagnostic procedure and you are unnecessarily subjecting a diagnosis.
So I think if it's a sub-centimeter node, particularly, you should integrate with clinical. If it is not fitting, you know, even in congestive heart failure, you might see a lymph node. That does not mean anything.
Recently, they said, I think one article said that even right paratracheal 4R in station 7, up to 2 centimeters is normal, they mentioned.
No, not that. I would not say.
I think a
sub-centimeter is...
centimeter, I think I would go with that thing.
Above centimeter, probably, you know, particularly in sarcoid, these patients are asymptomatic. But I think sub-centimeter, if it doesn't fit in your clinical, just discard them. Thank you, Dr. Karan.
One
Thank
more
you very much.
question. Oh, sorry. So, as you said, can we downstage before chemotherapy even? Before any chemotherapy, can we downstage on, we make a diagnosis like on, this is N3. Can we downstage also with EBUS?
Yeah, if it is negative.
In the sense that if your node, you have done adequate sampling, it was a positive node on the PET scan. But say you have sampled adequate material, lymphoid tissue, but no malignancy. And so that means that N3 which is lighting up is not positive on EBUS. So that way.
Other thing is don't go by SUV. I have seen only 3, 4 positive and even 8 being inflammatory.
And you have a setting when nothing is positive and still the node is positive. So, because there's a delay and the node may have come up before between the PET scan and the test time. That's the thing.
Thank you.
Thank you, sir, for the valuable time. Now it's the lecture time.
For the next lecture, I would like to call Dr. Praful Chauhan, sir, consultant in Department of Gastroenterology at Aryabhat Hospital, Meerut, to speak on the topic combined EBUS, EUS, mediastinal evaluation.
Give a big round of applause.
Should I start? Good morning, everyone. Myself, Dr. Praful. I am a gastroenterologist working in Aryavat Hospital as a consultant. So it is a wonderful conference so far, and lots of important decision, clinical scenarios, presentations, lymph node stations up to the date. And my topic is combined US and EBUS examination. Most of the part is covered yesterday's and today morning also. So I would like to highlight the important part, and I will cover the topic within as early as possible and just give the specification, data, what is real world scenario, what is the advantage, what is the disadvantage of US and EBUS. Okay. So endoscopic ultrasound and endobronchial ultrasound are not a competitor but a complementary tool to each other. Combined US and EBUS provide most of the complete and accurate mediastinal staging, particularly for the lungs cancer, and their advantage are defined by anatomical access, patient tolerance, and procedural efficacy. So evaluation of mediastinal staging US and EBUS is, US is come into picture in 1988, the linear, the first picture 1993, but it standardized in early 2000 and routinely diagnostic tool in 2005 and 2006. EBUS is invented in 2002 and mid 2000 to 2005 come into the picture. But the radial probe of EBUS is discovered in 1992. So why mediastinal evaluation is matter? Mediastinal is central hub, many vital structure, malignancies, lung and esophageal malignancy, lymph node station. Unfortunately, cross-section imaging, CT scan, PET scan, MRI not adequate to confirm the diagnosis. So there are the four anatomical composition: superior mediastinum contain great vessels, thoracic ducts, esophagus; anterior mediastinum contain lymph nodes; middle mediastinum contain hearts and important structures, ascending aorta, main bronchus, subcarinal station 7, and posteriorly descending aorta, esophagus, and lymph node station 8 and 9. So there is a central component of mediastinum lies between the two pleura, and three components, that is neck, thoracic cavity, and abdomen. Both the central cavity and peripheral cavity exchange their diseases and the transmitted diseases from the central component to the peripheral component to the central. So there is a station, 6 station standard. The respiratory landmarks are: first station is upper trachea, second is lower trachea, third is carina, fourth is the right bronchus, fifth is the right bronchus eparterial, and sixth is the left bronchus. The associated with the lymph node station, first station is 1, 2, right, left, and station 2 is 4, station 3 is 5, 7, 8, station 4 is 10, R, right R, station 5 is 12, 13, 14, and station 6, 10, 12, 13, 14. The vertebral landmark is important for the US examination, but EBUS examination is not that important. So what is the different probe that we are used? The extreme right one, that extreme left to me, that is radial probe. The radial probe is give you the exactly 360-degree rotation, exactly the good picture, but we cannot do the biopsy and anything. The medial one is EBUS score, smaller one, 6 centimeter, small working channel, curvilinear, and the extreme right is, that is EUS scope. That EBUS scope is curvilinear echoendoscope. The diameter is 6.7 mm, biopsy channel is 2 mm. Ultrasound frequency is 7.5 megahertz with penetration depth is 4 to 5. The penetration depth is more, the frequency is more, the picture clarity is more, but the penetration is limited. So the US scope is 20 megahertz, but the picture quality is extremely good, but penetration is limited. So in a EBUS scope, we use a 22 gauge needle for transbronchial aspiration and assess the lymph node adjacent to airway, ideal for the superior and the anterior mediastinum. The EBUS scope can identify the station anterior superior mediastinum, station 1, 2, 4, station 7, but the inferior mediastinum is difficult to assess. Radial are 270 to 70 degree assessment. So US scope is performed by the esophagus and access the posterior and inferior mediastinum better than, and you can access the liver, biliary tract, kidney, and adrenal gland also. So US is 20 hertz, good picture clarity, but penetration is not possible. The scope movable 100 to 180 degree, working channel is large. You can put a diagnostic and therapeutic to the same channel. And ideal for the station 8 and 9, and you can see the 7 station also, the enlarged lymph node station 5 also. But the pretracheal node 4L closer to esophagus and accessibility, but the node 4R is not usually unless it is enlarged. So International Association of a Study of Lung Cancer classify into the 5 station, that is supraclavicular, that is upper mediastinal, aortopulmonary, lower mediastinal and pulmonary. Lymph node station we already discussed a lot before, so I will move fast. That is supremediastinum cover 1, 2, 3, 4, inframediastinum 5 to 9. Their location, above the brachiocephalic vein, the upper pretracheal above the aortic arch and below the left brachiocephalic vein, the prevascular, prevertebral behind the esophagus and lower paratracheal below the margin of aortic arch and level of main bronchus. 5 subaortic, 6 paraortic, 7 subcarinal, very important. Station 5 and station 7, very good seen by the US examination. So these are the schematic representation, show the yellow one best seen by the US scope, the pink one best seen by the EBUS, and combined we can access the every part of the mediastinum. So combined EBUS and US sensitivity is 95%, complete mediastinal coverage can be done in single session. EBUS is best for the anterior and superior node and EBUS is best for the posterior and inferior nodes. So this is the landmark, that is the esophageal, upper esophageal, cervical part, upper thoracic, middle thoracic and lower thoracic. We divide the esophageal junction on the basis of this. The strength of EBUS is superior to the paratracheal and hilar lymph nodes, allow air inspection simultaneously, higher diagnostic yield, well established in the guideline. Strength of the US is only minimal invasive, can do in abdominal sites, adrenal and celiac nodes, the abdominal metastasis we can diagnose, tolerability is better. So needle size, the needle size is 19 gauge needle, the larger lumen we can use for the core biopsy, GIST, molecular testing. 22 gauge flexible needle we can use for US and EBUS. Normally used, routinely used. 25 gauge needle is very thin, hard to lesion vascular tumor, availability has issue. And we have the pre-core, star core and acquired needle for the Western histological sampling. So we talk about the real world scenario and data. A direct comparison study highlight the difference in efficacy and patient tolerability. Procedure time for EUS is faster and mean time is 13.1 minutes as compared to EBUS is 24.1 minutes when the sampling and similar number of sites can be examined. The sedation and recovery, the lower the mesadolam and fentanyl dose as result to shorter time and discharge as compared to 42 minutes versus 55 minutes in EBUS. So EBUS alone show the meta-analysis show the poor sensitivity 79%, specificity 97%, US alone is 74%, but if you combine together 86% sensitivity is increased. In 2022 study show that 211 US FNA procedure reported in overall sensitivity 85% with sensitivity of 87%. With acquired and paramediastinal masses reaching up to 96.8%. And we have in before my EBUS and cytobiopsy is a newer technique that we combine EBUS and high diagnostic yield and standard EBUS. So at the end of the slides, I would like to give the comparison. The endoscopic ultrasound is better, no cuff. When the endoscopic ultrasound is contraindicated, when patient is obese, then fall in saturation, not able to tolerate procedure, you can do it as early as possible. Average time is 5 to 15 minutes. And for endobronchial is 10 to 13 minutes. The ultrasound window is 150 to 180 minutes, larger window we have, and EBUS we have smaller window, better image quality, and the larger broad elevator we can use the larger core biopsy with the endoscopic ultrasound. So this is the image showing that the US examination is not enough for TNM staging because 40% of lung malignancy show the distal metastasis. We have the lymph node metastasis, left adrenal metastasis, left lobe involvement, paratracheal intrapulmonary thrombolysin and mediastinal invasion also. So combine US and EBUS, we can reach and we can conclude the diagnosis when there is a multi-system disease and the involvement of the thoracics and abdomen consider. So giving up does not always mean you are weaker. Something it just mean you are strong enough to let go. So after this, I would like to complete my today's session. Thank you.
Yes. Thank you, sir, for covering such a exhaustive topic in brief and pointing out all the important things need to be kept in mind. So one most important thing that you highlighted in the beginning, that EBUS and EUS are not competitors.
Yes.
And they need to be treated as tools which can provide which can go complementarily and provide benefit to the patient. Also, as earlier highlighted in previous sessions, we need to see the patient as a whole and see the lesion, where is the lesion and what modality is most amenable to sampling, whether it be a CT guided biopsy or an EBUS guided FNAC or an EUS guided FNAC. So thank you, sir. Are there any questions from the audience?
Thank you. Thank you very much.
Thank you, sir.
Thank you, sir, for the lecture. Now we are going ahead for the live demonstration. Kindly be attentive and feel free to ask questions during the live demonstration.
So we'll be moving towards the live demonstrations. Are we audible in the hall? We are live, sir.
Okay.
Okay.
So, good afternoon, everyone. And this is a case of around 60-year male who has come with weight loss under evaluation. And CT shows abdominal lymphadenopathy in this patient. So, also the point of view is here to examine the abdomen as well as mediastinum. So, first we'll be evaluating for the mediastinum and also to examine the nodes and possible to do a sample nodes. If
So
we
we
get
will not
any.
show how you sample the abdominal node, but
Yeah.
first demonstrate the mediastinum
because
this is a mediastinum endoscopic ultrasound
Yeah.
workshop. So how do you want to demonstrate mediastinum as a sonograph?
So yeah, so mediastinum like similar to like USB. So as we know, the examination, if you have referred for examination of the mediastinum, the examination starts from the abdomen. So obviously we know that station 9 and 8, and which is not, we are not able to sample through EBUS. So the first is we examine the liver, and the moment we enter the abdomen and we see the left top of the liver, which is you can see in the screen, and since ultrasound is a 2D image and liver is a 3D structure, in one plane we just cannot examine the entire liver, so we roll the ultrasound scope. So also there is a paper which suggests that even CT is negative in like abdominal malignancy, there is 6% chance that ultrasound or EUS will pick up and some liver lesions. So this is the first thing we look. Also, apart from the liver, we also look for the left adrenal, and if possible also we look for the right adrenal. But
so where will you look for right adrenal?
Sir, for right adrenal, we cannot look for from G junction. It is difficult.
But we will show probably if we can find the IVC, so right adrenal may lie behind the IVC.
Yes.
So the trick to look for right adrenal is, so let us see if we can find the IVC now.
Okay. So right adrenal is closer to the duodenum. So if you want,
we will not go from duodenum because their scope will not reach the duodenum. Let us see. If we can tell this audience, and trace the IVC. If we rotate, we will find. I am tracing.
So yeah. So if you rotate here clockwise, you land at land at pota.
This is the IVC.
Further clockwise, you see that there is a structure, and
this is the pulsatile.
Anechoic structure within the liver parenchyma, which is fairly large vessels, and this is your IVC.
and you rotate, it will go into the abdomen.
So we trace
Clockwise.
the IVC and withdraw the scope and rotate. As we know, the IVC drains into the right atrium. So you can see in the screen there
This is
IVC.
the upper part. Can you trace the lower part?
This is
Because the lower part will show you adrenal.
okay.
When you cross and here, if it goes, if we can see the IVC and the right kidney, we are sure enough we will be able to find the right adrenal.
So I think it is patient is obese and we have to decrease the frequency to.
We have already decreased the frequency, but I believe rotate clockwise, and I think we are finding the right adrenal approximately. Because this particular place, this is the right adrenal, which is behind the IVC when we rotate it. So this is how you see the right adrenal behind the IVC. This will be above the kidney. So,
but sampling right adrenal will be difficult.
Sampling is difficult. So now can you show the left adrenal and then come to mediastinum?
Okay. So anyway, so just 1 second. So we just saw IVC, which is draining into the right atrium, and also you can see there is a straight structure vein which is below the IVC, and that is a hepatic vein. Which hepatic vein they drain into IVC. Okay.
So I think we can leave the left adrenal. It has been demonstrated. We can come back to mediastinum.
Mediastinum. So once we see the IVC and we pull out and rotate anti-clockwise, and once you rotate anti-clockwise, we see the right atrium.
This is the right atrium.
Yes. And there is we can label it right atrium.
Okay, keep on showing.
So at the level of where IVC drains the right atrium, there is the location of the station 9 node.
Yeah. So this is station 9 node.
Station 9,
here,
yes.
But it will be below the pulmonary vein.
Yes. So then we see the right atrium. We further withdraw our scope and rotate anti-clockwise.
So this is here, where below the pulmonary vein, this is the place where you will expect the station 9.
Station 9 node. So you can further rotate further, and this is what you are saying is now left atrium and interarterial septum.
You have to rotate the left atrium further.
So septum has a thin part which is septum primum in the top, and thicker part at the base.
Thicker part at the base, and then
that is primum.
So this is primum. This is primum.
Thinner is primum, thicker is secundum.
So this is which one? You will say this is primum.
Yes.
And this is secundum.
This is secundum.
Secundum is on both sides.
Sir, it should be one side only, no?
Because it should be circumferential, but anyway we have. No, what do you think? Septum primum on secundum.
Sorry.
Idea?
Primum will be in the center because we are seeing the 2D. Secundum will be all around. So
secundum, and also the primum is the septum, which changes which is floppy, which will move more left this side or this side.
So
rotate.
This is where you find out arterial septal defect through transesophageal echocardiography, and also you can find in EBUS.
So right now this is the left atrium. This is secundum. This is primum. This is right atrium. This is IVC, IVC.
Inferior vena cava, that is.
And here, this is the SVC. This is the.
So faintly, we rotate slightly clockwise, we will see superior vena cava.
This is and this total is the left ventricular outflow, right? So this is the right ventricular outflow tract. This is the right ventricular outflow tract.
So below the SVC.
Okay. So now we come slightly higher up more.
We come slightly higher up. Now what we see?
This is the area of valves.
Yes. So here we see the superior vena cava.
Can we put in bubble around?
Okay.
So there we see the superior vena cava, which will come in between the left atrium and aorta.
And this is the superior vena cava.
This is the superior vena cava. So, but can you show the valves, the four valves?
Yes.
Rotate, just rotate.
So rotate anti-clockwise. You can see this is root of aorta.
And this is the mitral valve. So we see right now two valves. This is the aortic wall, this is the tricuspid wall, and here we will see the mitral wall. Let us see the mitral wall. Now this is the mitral wall that
So we are seeing the mitral valve.
and you can see this is the left ventricle which has got very thick chamber. So this is the thickest chamber. So this is the mitral wall, left atrium, left ventricle, left atrial appendages. Okay.
So you can see this is mitral valve. Another way to identify this thick wall, one of the ventricle, which is left ventricle, which is more thicker than the right, and the valve is bicuspid valve.
Now this is the right ventricle, and from here
This is your left ventricle. Then further you
This is right
This is your right ventricle.
okay. So probably you can come to
For the
pulmonary
pulmonary
artery. Yeah. Okay. So now
So
we push.
Yeah. We want to see bubbles.
No, no. We want to see whether the bubbles come into the right atrium or not.
Okay. So then I have to push it.
No, he will, because these are the bubbles will come into this. Yeah. So superior vena cava. This no other way, clockwise. Yeah, more clockwise.
Yeah.
This is the place where we expect the bubbles to come into the right atrium.
Yeah.
Injector?
Yeah. We started.
No.
Maybe not.
So the bubbles did not appear, but sometimes they will be. But this
One more time you can try it.
one more time. Because this is the superior vena
Yeah,
cava.
we see something.
This is the inferior vena cava.
We see some
And
bubbles.
these are the
Yeah, we
bubbles.
see bubbles.
So we will see. We will show you that this way you can outline whole of the right ventricular outflow tract, because this is the right atrium. The bubbles came from superior vena cava and they entered into this chamber.
So we injected some agitated saline and which has bubbles, and we saw in the right atrium. So now further mediastinal evaluation, we
Further only 6 more minutes left, I think. Praful, we can be ready with the next lecture because the demonstration will be over. Huh? No. We continue with lecture. We continue with lecture, 2 lectures then. Huh? No, whatever is the finish of the lecture, we cannot.
So we further withdraw.
Because we are online also, no?
So we further withdraw, and now we'll end up in a space that is subcarinal space.
Okay, now we are talking of the subcarinal space. Now this is trachea and this is subcarinal space.
Yes.
Pull back a little bit more.
You can see ring.
So these are the rings that you saw. So these are the tracheal rings, reverberating rings, which we can see. You can see now. These are the reverberating rings, and these are the tracheal reverberating rings that we are seeing. So this below this is the point, is the subcarinal area.
So it is bounded by, it's a left atrium, right pulmonary artery and bronchus. So that is why the station 7 node and location.
So can you now pull back more? Arch of aorta, the area of arches.
Yes. So for the arch of aorta, we have to rotate the echo endoscope 180 degree because it is located posteriorly. So if you rotate 180 degree from the subcarinal space, you'll end up and see the arch of aorta, and here is the location where the station 8 nodes are located.
So this is the para-aortic area, along with if they late, they will look at you. So this is the arch of aorta. This is the arch of aorta. Right. So we'll now record it and we'll see, discuss it. So can you rotate and see the azygos vein arch on the other side?
Okay. Scuffing.
Other way? Yeah, this is the azygos vein arch.
So,
yes. So we will freeze it. We can remove the scope because the patient is uncomfortable. Remove. The patient is uncomfortable. So we are reviewing this because this is the azygos vein arch that we are seeing, and this is the azygos vein arch we are seeing. So this is. So we are done with the demonstration of this azygos vein arch. In this case, we could show the demonstration of the different arches
So we could demonstrate azygos vein arch, aortic arch, the subarch area, the subcarinal area, the left atrium area, and the area close to the diaphragm, where we saw the superior and inferior vena cava and the area of cardiac chamber and the area of pulmonary valves. So we could not efficiently demonstrate the
other
rest of the
stations.
So we have been using two types of scopes today. We have been using Fuji scope for EUS. We have been using Pentax scope for EBUS, and now we have people are more familiar. Some of our faculty are more familiar now with the.
For the next lecture, as chairpersons, I would like to invite Dr. Rahbar Khan sir and Dr. Sanjeev Jain sir, renowned pulmonologist at Fortis Hospital, Shalimar Bagh, New Delhi. And for the lecture, I would like to invite Dr. Aman Ahuja sir, Assistant Professor at Pandit Bhagwat Dayal Sharma, PG Institute of Medical Sciences, Rohtak, to speak on the topic, should EUS be included in pulmonary medicine curriculum?
So which one? Also precision. Very warm good afternoon to you. I would like to thank organizers for giving me the opportunity to be here. I'm myself Dr. Aman. I am Assistant Professor in Department of Pulmonary and Critical Care Medicine at PGIMS Rohtak. So before starting the presentation, I would like to give a viewer discretion because the domain is primarily of a gastroenterologist, but mediastinal sampling is incomplete if we don't evaluate by the esophageal route. And there are certain scenarios where a pulmonologist cannot diagnose or cannot help the patient without approaching through the mediastinal route, through the esophageal route. So we have read a lot, we have listened a lot. Anyone can briefly just tell me a single point difference between the EBUS and EUS, what you will say to the attendant who is guiding you in the procedure? Gross difference between the sampling between the EBUS and EUS. Or it's almost the same, anyone can do, who is doing that can do this one also. So basically the major difference comes is when you do an EBUS, when you are entering or sampling the needle, you guide your attendant to push the scope while you are entering the needle because there is a loss of contact. Trachea has a cartilaginous structure which is relatively rigid. So as you enter, when you sample the lymph node, there is a loss of contact, and during that time, vision will be lost if you don't push your scope. If you do the same in the EUS, you will tear up the whole esophagus. So the gross difference which everyone has to remember is that during an EBUS scope, usually a push is required when we are sampling, but in EBUS, in EUS, it is not required. Other is in EBUS we do a slow jab because we always want that the thing should be in the real time and under vision. And in EUS we do jabbing. We just insert the needle without fearing about that. And these are the two major differences between the EUS and EBUS technique. Otherwise, rest of that, it doesn't make much of a difference. We can both the route, we can sample by the 19 gauge needle or 22 gauge needle, and the field of view is bit less in the EBUS compared to EUS, but otherwise there is not much of a difference. So I'll not discuss the theory part. I'll show you some cases and let you decide whether a pulmonologist should know about the EUS-B or whether a pulmonologist should do a EUS or not. So I present a case of a 60-year-old lady. This lady presented to us, she was a smoker, presented with acute onset of breathlessness. She was in type 2 respiratory failure, and caregiver said that she had some sort of abnormal noise while breathing for last 2-3 days. So we went ahead and we intubated the patient in view of the CO2 narcosis and altered sensorium. And later on, because as soon as we intubated the patient was out of distress and she was very comfortable, and we wanted to evaluate that whether some other abnormality we are missing. So we went ahead and did a CT scan. So this CT scan was showing a cystic lesion in the posterior mediastinum, which was compressing the trachea, and we went ahead, we did an EUS guided aspiration, and we could aspirate about 60 ml of serosanguinous fluid, which later clotted on the after the sample collection. So we did analysis of the fluid, complete analysis. Everything was negative, and it was just, the slide was also showing the neutrophil and mucus embedded in RBCs. And our diagnosis was mediastinal cyst, that was probably androgenic mediastinal cyst compressing the trachea from posterior wall. So this patient was successfully extubated, and we can see that after 18 months there is no relapse or recurrence of the cyst, and patient is comfortable. The same was also published in Lung India as a case report. So another case, this is a 36-year-old gentleman presented with dry cough for last 1 year, and patient was on ATT for last 9 months and had a 7 kg weight loss even after taking ATT, and presented with right-sided chest pain and hemopsis. So typically evaluation by a pulmonologist, hemopsis is there, you will get an endobronchial mass, endobronchial lesion. So there was an endobronchial lesion. We did an endobronchial biopsy. We did it on 2 occasions, but both the occasion it just showed the necrotic material, and we could not make a diagnosis even after getting a very good sample. So second option would be like, why you don't do an ultrasound guided transthoracic aspiration, transthoracic biopsy. So we tried that, but this was showing more of a consolidation rather than a mass. So we avoided that, and because after 2 occasions we could not get a yield from the endobronchial biopsy, we went ahead and did an EUS FNA from the right hilar mass, and we could, you can see that in the report that this lesion came out to be a primary pulmonary lymphoma, which is a very rare diagnosis, and we could get so good amount of the sample that we could do so much of an IHC, and even after that the sample was not exhausted, and we could make a diagnosis of a rare disease, that is B cell type of lymphoproliferative disorder. Lymphoma is one such scenario where the amount of sample required is more, and biopsy is more confirmative rather than an FNA. But after making cell block, we are getting such a good sample that even lymphoma we are diagnosing with EUS and EBUS. So this is a routine case, what we do in we see in our general practice, like a smoker presenting with cough and weight loss and presenting with a right hilar mass. So in this patient we did a bronchoscopy which was showing extrinsic compression. We had option of doing EBUS and EUS both, but the ease patient have in EUS is much more than EBUS. And both the procedure we are getting adequate sample. So if we have an option to do EBUS or EUS in a same patient, we'll prefer EUS because patient doesn't have any cough, patient is very comfortable in EUS, whereas in EBUS, usually patient have more difficulty with the scope. So one more case. So this gentleman, this gentleman came to us. He was a smoker with chest pain and shortness of breath, and he underwent a bronchoscopy in some private hospital where he was advised that he is having some extrinsic compression of right upper lobe, and he is very sick to get any treatment, and they advised him for palliative care. So patient came to us for second opinion whether something could be done in this patient. So we find out that patient has a large paratracheal mass which is compressing the SVC, and patient is in SVC syndrome with bilateral pleural effusion. He was so dyspneic, he was unable to lie down. He was not fit for any procedure. So as for the ECOG status, he is not fit for any therapy, and you should send him home and ask him to get a comfort care. So we denied that. We started him on treatment for SVC. We gave him some diuretics, and we went ahead and did an EUS from this subcarinal lymph node. This we could sample EUS, EUS scope, because there is no respiratory distress, patient is very comfortable. We did an EUS by bronchoscope, and we could get the sample, and on the same site we did a ROSE. ROSE was showing small cell carcinoma. Before getting the final report, we were sure that, pathologist was sure that this is small cell carcinoma. We gave the patient chemotherapy, and patient was discharged off oxygen within 5 days of admission. So this is the magic that EUS by a bronchoscope give us, the power that bronchoscope, this EBUS guided EUS give us. So within 4 days we could diagnose the patient, we could give them chemotherapy, and we discharged the patient, and patient improved after the cycle of the chemotherapy. So another case, this patient presented to us with in stridor, smoker with orthopnea and stridor, and we could see there is a large subcarinal mass, right hilar and the subcarinal mass, which is compressing the left and right main bronchus. So patient was very dyspneic, was unable to lie down, required high flow oxygen. So we did a rigid bronchoscopy guided stenting, and we put a Y stent. After putting the Y stent, we have to get a sample also. So for sampling, we did our EUS-B, and we got the sample from the subcarinal lymph node, which showed squamous cell carcinoma, and patient was discharged after giving the chemotherapy. So in such scenario also, where you have patient is very dyspneic, you have to put a stent to decrease the dyspnea, and post stent we cannot take the sample from the trachea because already there is a stent in situ. So EUS-B gave us the option to sample this patient. Last is an interesting case. Just in last procedure, we had a patient which presented to us with a mass in the upper cervical region. We can see that there is a destruction of the vertebra, and this destruction, there is a mass causing the invading the vertebra in the cervical region. And if we see by the EBUS, it's just below the vocal cord in the subglottis region in the posterior mediastinum. So, and there was another lesion in the lung, which is just a very small, about 2 centimeter lesion in the periphery of the lung, this one and this one, and most likely in the apical segment of the right upper lobe. So, to sample, now we have two options. Either we go ahead and do a radial EBUS where we have a 40% chance that we will get a yield, or we have an option to do a EUS-B and get the sample from the this lesion. And because it's in the posterior mediastinum, and by EBUS we cannot sample in the region of the subglottis or vocal cord. It's very difficult. Patient won't let the scope stay there at that position. But by EUS it is possible to sample this lesion. So we sample this lesion by the EUS-B, and we got by ROSE we got the sample that it is in favor of malignancy. So we'll definitely get the result within few days, and we can also start treatment for this patient. So finally I would like to conclude, like, when you would like to do, when a pulmonologist should do an EUS-B. So whenever there is a posterior mediastinum lesion which need to be evaluated, it is only possible by EUSP. EBUS won't be able to diagnose it, or you have to go for the lymph node station 8 or 9. EBUS won't be able to do it, only you can go it by the esophageal route. Other is whenever patient is in respiratory distress, patient usually are of smoker with COPD background, and they'll have so much distress that you can't put a bronchoscope or an EBUS. You can easily do an EUS and diagnose the same. So even for the subcarinal lesion where you can approach both by the EBUS and EUS, EUS would be preferred if there is a concern for patient safety. And whenever in respiratory distress, we go ahead and usually do EBUS, we do EUS by our scope. So other would be that 4L region. 4L is the left paratracheal node, which is the AP window. Aorta and pulmonary artery would be there. So that window sampling is very easy by the EUS, and it's bit challenging if we have to do it by the EBUS scope. So we'll prefer it for the left paratracheal, for the subcarinal in those patients who are not stable or those who are having respiratory distress. Whenever there is a central airway lesion or the stenosis or any distortion of the anatomy, other would be if there is a less bleeding risk by the esophageal route, we'll prefer that. And last would be if you want to sample the left adrenal, though it is bit challenging by the EBUS scope to sample the left adrenal, but it can be sampled after proper training. So thank you for your patience listening.
Any question from audience? Thank you. Nice talk.
Thank you so much, Dr. Aman Ahuja sir, and thank you so much, Dr. Rabar Khan sir.
Now, I would like to call Dr. Atish Patnaik sir, who is a renowned gastroenterologist from AIMS Rishikesh, to guide us on image optimizing in lung ultrasound, EUS and EBUS. Please, sir, come.
इसमें डेस्कटॉप में हाँ डेस्कटॉप में लोड है इसको मिनिमाइज कर दो आ जाएगा स्क्रॉल नहीं आ रहा है इसमें हैंग हो गया ये है
So, good afternoon everyone, and I thank Dr. Malay for giving me this opportunity. So my topic is image optimization in lung ultrasound. So I was given both EBUS and EBUS, so I'm a gastroenterologist and I don't do EBUS. So when I went through the literature, the image optimization in lung ultrasound, I think we have very minimal literature for image optimization during EBUS. So I think this topic is useful as most of us, they do ignore this image optimization and are not familiar with the control of the image optimization. So image optimization means we process an image and deliver a high quality image, and which is of optimal size and resolution. So there are different image optimization: B mode, color Doppler, spectral Doppler, and due to lack of time we'll be focusing on B mode imaging only. So as we know, this ultrasound is produced by, it is just a sound wave with a frequency higher than what human ear can hear. And as we have a transducer which have piezoelectric crystals, as we excite them and they generate echoes or waves which passes through the tissues. So once this waves they pass through the tissue. The tissue also generate echoes, and they are received by the transducer, and ultimately it is processed by a ultrasound processor, and what we saw in image. So what we see is what is not generated from the transducer, rather what the transducer receives from the surrounding structure. So what happens to the ultrasound in our body? The ultrasound wave, part of the wave that gets reflected from the tissue. Also, the ultrasound waves get scattered by tissue, and also there is something called refraction. If ultrasound waves passes through a medium and its velocity differs, so that is called refraction. As ultrasound beam weakens, and because of the increase of depth, then that is called attenuation. So in this picture you can see that there is a cystic fluid, and that doesn't attenuate that ultrasound beam, so lead to posterior acoustic enhancement. The middle picture, there is a strong reflector, that is a air pleural, so we get some dirty artifacts. And also here in the gallbladder you can see some stones which strongly attenuates the ultrasound beams. That is why we see the posterior acoustic shadow. So there are other concepts of the ultrasound, and which is acoustic impedance, or that is called resistance. So you see there is a three structure. Anechoic areas are through anechoic areas like vessels or cysts, the ultrasound beam passes without any attenuation, and there is no beam gets reflected from the anechoic area to the probe. So that is why that area is that devoid of echoes, and that is called anechoic area. Hypoechoic area, they have some resistance and some returning waves, and below you can see there is a hyperechoic area which is like fat, which is like a produce strong echo as it returns higher amplitude of ultrasound waves to the probe. So this fibrous tissue or fatty tissue, they have a stronger echogenicity and they have higher acoustic resistance. There are one or two more concepts that is coming to the resolution of the ultrasound, that is spatial resolution and temporal resolution. So when you see the axial resolution, that is resolution means the ability of the ultrasound beam to differentiate between the two structure. So this is the low frequency wave, and this is interpreting as a single image, but once you increase the frequency, the two points are seen as the 2 points. That is due to increased frequency increases the axial resolution, that is along the axis of the ultrasound beam. So there is another resolution which is called lateral resolution, which is perpendicular to the axis of the ultrasound beam, and this depends on the beam width or scanning width, and also the axial resolution depends on how dense are the beam here. So if you have increased the scanning lines, then obviously the axial resolution will increase. If you have a narrow scanning window, then also the beam density increases, which increases the lateral resolution. There is another thing, temporal resolution, which that is ability to image the fast objects. That is called temporal resolution, like for cardiac chambers. So obviously dark room is a mandatory, and we have ultrasound monitors. Now the Ariata 850 has OLED monitor which has higher contrast. Also we have transducer like radial and linear, curvilinear transducers. So there are basic difference between EBUS and EBUS scope. Like EBUS scopes are designed, they are slim, they are flexible, they are designed to pass through into the airway and do imaging and also sampling. EBUS scopes are bulky, but advantage of the EBUS scope, they have lower frequency for deeper imaging, and they have wider channel for EGFR biopsy. Their field of view of scanning is also higher compared to the EBUS scope. So we gastroenterologists, we come to picture when there is a tracheal narrowing and EBUS is not possible, there is friable bronchial tissue, there is risk of bleeding during US FNB, that is why then you perform EUS, and also there is high risk of anesthesia or coagulopathy, there is risk of bleeding. Also there is many centers, they do not routinely do EUSB, so the lack of expertise also there, and whenever you need a complete mediastinoscopy for staging of lung cancer. So obviously already we have discussed that indication, you can use a balloon for increased acoustic coupling. Then the second part of the image optimization is knobology, that means to know your EUS settings or knobs. So this is the first thing we are coming to the depth. Depth means what is the scanning range and how deep you want to examine. So if you do not, suppose your area of interest is subcarinal node, you do not want this area to examine, so this information is unwanted. So in that case you can enlarge the image, or you can decrease the depth, so the area of interest is very close, and also it increases the resolution. So you can see in the images, and you see that is framing is 40 frame per second. So suddenly we decrease the depth and your frame rate has gone up. So the increased frame rate increases the temporal resolution, especially useful for fast moving object. So usually depth, your ideal depth is the area of interest should fit the skin. That is the ideal depth you require, and you do not need unwanted information. Focus is the area where the ultrasound beam is the densest and the resolution is the highest. You can have 1 or 2 focal area. You can choose it. So if you choose more focal area, the frame rate drops, and ideally you supposed to get at least 20 frame rates for a better imaging. So here also you can see the focal area. If you want to examine the subcanal area, the focal area should be like just below the subcanal nodes. So that is why the increased resolution in the subcanal area you can get. You don't want your focal length to here. Similarly, this is frequency. Frequency is just number of oscillations. If you have a higher frequency, the penetration will go down and resolution will increase. So depending on the structure, if you want a fast structure imaging evaluation, then you use a low frequency. Otherwise, you can use a higher frequency if you want a structure evaluation like closer to your transducer. So this is the lever. You can see that is we are imaging at the 5 Hz. Once you increase the frequency, you can see the deeper structure are barely visible and the resolution of the lever increases. So once we are decreasing frequency, you see the deeper structure are more clearly visible because the penetration is better while it decreases the resolution. So frequency according to if you need a high spatial resolution and the structure is close to the transducer. Then gain is overall brightness. Usually during initial period, like when you start doing ultrasound, usually you keep the gain high, and over the time being, once you are expert, you keep the gain to the optimum. So the gain overall increases the brightness of the imaging. So here is the gain, and it's 7. So once we are increasing gain, the brightness of the images is more. So now we are decreasing the gain. So ideal gain is that the vessels should be anechoic and the walls is hyperechoic. So that is why we called ideal gain. Time gain compensation, if you do a gain, the entire area is brightened or blacked. But time gain compensation, if you need only the distal structure which is not or gain is low and you want to better visualize the distal structure, you want to increase the gain only the distal part. You have controls in the ultrasound, like you can increase the gain according to centimeter depth. So here is the ultrasound, and you can see there is a subcanal node. Below the structures are not clearly visible if you at all you want to see. So I am increasing the gain here, the distally, the deeper structures. So once you gain, you can see the structure deep to the ultrasound, the gain is now appearing more bright. So this is what you can adjust. So advantage is that it will not increase the gain of the nearest structure or superficial structure, but increases the gain of the deeper structure. So anyway, this is again, one is called contrast, and that is a shade of gray. Normally we keep the contrast low, and so low contrast will give you more finer detail. If you increase the contrast, you will be seeing more shades of black and white. Images appears more grainy, and that's why we reduce the contrast to have softer images. So then we have many application presets. I think GI, pulmonary, respiratory, a lot of that. But most of the US indication, I think no single setting is useful. I think operator has to use the best image possible and adjust according to the personal preference as well as the patient's habitus. So another, this is new thing, that is low echo reduction. Here it is different from other thing because here the darker areas are suppressed, but the brighter areas are not increased. So there is a function you can increase or decrease the low echo reduction. You can see the pancreatic cyst here. So we reduce further, it reduces the low echo. We can see the cyst, the right side image, D image, you can see the wall of the cyst is more prominent. So that is one. Line density already I have spoken. So line density, if it is scanning angle is narrow, line density will be higher. You can manually also increases the line density. If you increase more line density, more denser waves, it decreases the frame rate. So line density also useful sometimes. which increases the lateral resolution. Now the transmission power by default, this is not useful for us because EUS or EBUS scopes, they are already 100% power is there. It is especially useful for pregnant women where you do not want high power to be get delivered to the newborn. So once you reduce the power, you see the ultrasound signal is now more darker and darker. And since now we are increasing the power output or acoustic output, again the image is becoming more brighter. So we rarely adjust transmission power in our ultrasound. Signal to noise ratio, signal what we want, noise what we do not want. And I think that there is some adjustment you can do like harmonic or increase frequency, decrease frequency and do the signal. There is one or two more slides. That is one is compound imaging. So ultrasound probe images in different direction. If I combine all three and produce one image, that is called compound image. But the problem with the compound image, if you three images will be converted to one, which have ultimately lower frame rate. Obviously, it will give a better resolution, but it is not there for fast moving object. The images looks more smoother than compound imaging. Last, tissue harmonic. When a transducer produces an ultrasound and it has a generated frequency, at the deeper level, the tissue generate frequency which is like multiple of fundamental frequency. Like if we are imaging at 3 megahertz, then the harmonic will be like 2 times or 3 times the 3 megahertz. So ultimately, by applying filter, we only image the harmonics. So the advantage of harmonic, it generates at the deeper and the superficial artifacts are not there. Both axial resolution as well as the temporal axial resolution and lateral resolution is high, but it decreases the frame rate. So this is example of tissue harmonic, and where we see we are examining the liver, and by applying the tissue harmonic, we can see the resolution increases of the liver. The vessel artifact in the vessel, they are also less. So it has certain use, obviously, and reduces certain artifact like side lobe artifact, but the penetration is poor in the tissue harmonic. So obviously, for the final few slides, so if you have controls, if you are not getting an optimal image, so always look for like whether your depth is too high, focal zone is incorrectly placed, gain is high, whether frequency is too low, or your contrast is high. Also, it depends on body habitus of the patient, physician experience, as well as the outdated equipment. 6th step, power 100%, gain accordingly, frequency. If you close structure, frequency high, deeper structure, frequency low. And depth of penetration, obviously, we don't want the image to ultrasound beam to travel very deeper. The area of interest, at the area of interest, we should focus our depth. Focal zone at the level of interest to get a higher resolution. Further settings are also required if required. Artifacts I am not discussing, already discussed. So to get a best use image, know the basic, know your knobs and minimize artifact. There are 3 only principles. Yeah, so any question we'll discuss. Yeah.
Thank you, sir, for the lecture.
For the last lecture, I would like to call Dr. Sangram Sadashiv Jadhav, sir, a senior consultant in Department of Gastroenterology at Aryavarth Hospital, to speak on the topic use of mediastinal EUS and EBUS in extrapulmonary lesions.
Slides, please. Slides नहीं आ रही. क्या चल रहा है? चल रहा है. Okay. So we have a change. We'll go for live demonstrations first. One case is pending. So after that, we'll have the last lecture.
Okay. Can you hear me from hall?
Yes, yes. We can
Okay,
hear
so
you.
this is gentleman, 60-year-old, diabetic patient having history of loss of weight and fever. And on CT chest, he is having multiple mediastinal lymph nodes. So you have seen two equipments since yesterday, Fuji and Pentax. And this is the Olympus scope 190. And you can see this patient is fully conscious. एक बार हाथ उठाओ, दिखाना हाथ उठाओ. Patient is fully conscious, and this is the 190 scope, and we will try to do this nasal route, how we can do like simple bronchoscopy to put through the nasal route EBUS examination. So you have to choose the best passage, larger passage like in bronchoscopy you do, and you are in the pharynx. जी बाहर निकालो जी बाहर निकालो. Xylocaine. Push. Like another bronchoscopy, you have to put xylocaine to properly anesthetize this area. Section करो, section करो. मुंह खोलो. लगा. Xylocaine. Xylocaine. Push and go. So these are the vocal cords you can see here. The technique, as I said in the morning lecture, you have to see the anterior commissure of the vocal cords, so you can directly go by touching this anterior commissure and just anti-flex your scope, and you are inside the trachea. First important thing is to visualize this trachea properly, tracheobronchial tree, any mass, any vessel, any obstruction is there or not, and putting some local xylocaine, 1% xylocaine, as you do in the bronchoscopy. So you see, this is a simple way of doing nasal route, and patient is fully conscious, no problem. And this patient, we are doing the EBUS through the nasal route. And now switch Olympus, Olympus, switch. Yes, now we can switch this endoscopic image to the smaller one, and when you touch these tracheal walls, you can start visualizing the different lymph nodes that are the mediastinal lymph node. And here you can see the larger one is coming up, is the station 4R, and this SVC is there. Can you put Doppler here? Doppler. Doppler साइड में, नीचे नीचे लाओ उसको कर्सर से. Nichala, all out. So this is the large SVC you can see, and above that lymph node is a 4R. Remove it. Now, when you go, you see this is the superior vena cava, and this is large one is the azygous vein that is draining into the SVC. This is the, you can appreciate above lymph node is a 4R, and this azygous vein, can you put Doppler here? Upar cursor. This is not color, is not coming up. Different hoga. Doppler, this color is not visible, but you can appreciate the whitish. This is a azygous vein that is draining into the SVC. And any lymph node below that is the, like this. This is the station 4R lymph node. You can appreciate here, you are in the right bronchus and you are touching the right upper lobe, and this is the azygous vein just above, and below that is the 4R station. Now, this is the carina. First we will see the left 2L position, if that is the yes. There is a niche, you can see large, the pulse. This is the previous one, the ME1 ultrasound, now M3 is available. You can see this is the 4L station, below is the pulmonary artery, left pulmonary artery, and above this one is the, this is the aorta. So this is the Mickey Mouse sign typical. So this is the, you have seen station 4R, 10R, and this is the 4L lymph node, and quite large lymph node. Now you can visualize, can you put xylocaine a little bit? To clean it, you have to either saline or you can put xylocaine to visualize the endoscopic image properly. Just not keep that only. Now, when you touch the lateral wall of the both sides of carina, you can visualize. Can you make depth lower? Can you decrease the depth? Decrease. Yes. So this is the large carinal, subcarinal lymph node. You can see beautifully visible from the left side, and when you go from the right side, even you can see there's the station 7, and below there's the pulsating structure is the heart. So this is the non-homogeneous lymph node. Necrosis is there. You can visualize very beautifully. So this is the station 7. And when you go down into the lower lobe, even you can see the different station 11, superior and inferior. Inferior lymph node you can appreciate here is a small vessel is there, along with is a lymph node that is a 11 inferior, right? And when you go again, you touch the lateral wall on the intermediate bronchus intermediate, you can visualize this is a large subcarinal lymph node. So we can take FNAC from here, and then I will demonstrate later on. Can you give the needle? Your turn. This is the Cook needle we are having. उसको कर लो बड़ा endoscopic image. So again you have to see the endoscopic image, and you can visualize the sheath is out. First step is to take out the sheath, and it should be only crescent shape size, not too large, too long, otherwise it will hinder the proper FNAC of the. So important step, again sharpen this needle by taking out this stylet out little bit, and you have to again search this lymph node, can convert. So this is the lymph node, Rahul, hold it. 1% to have to hold the full assembly scope at the nose level, and this is the time. This lymph node is quite large, almost 3 centimeter. So now the puncture, you have to do the puncture of this lymph node, and again put this stylet inside the needle. So clearing of to clear the any debris is coming up inside the lymph node. Now slowly take out. This is the capillary technique. When you puncture slowly, and when you puncturing slowly, you have to take out the stellate from the needle. This is the first step, should be like this. In next step, if sample is not proper, then you can apply little bit 5 to 10 centimeter of water, negative suction above this needle. So we have done, no, just here. So this is the first pass. We have done endoscopic image. Yes. So patient is quite awake. Rajkumar, haath uthao. Patient is quite comfortable. We are doing this EBUS through nose. Can you show this nose? We are going through the right nasal passage. We have done first pass of EBUS. Patient has comfortably stable, no any arrhythmias. Patient saturation is 100%, and patient is quite comfortable. So my message is through this conference that even with in severe patients, sick patients, you can do this EBUS very easily, like bronchoscopy used to do through nasal passage. The lumposcope, 190 scope is quite thin scope. You can pass easily, and you can do the same procedure as you do in the conscious sedation or with LMA or with general anesthesia. So don't be worried about this doing this procedure with the material here. Material? That material is there. We will take another pass with the same lymph node, shift ultrasonic image. Any question in between, Dr. Malasa, from audience? If they want to ask any question, then we have to prepare the needle. You can see the structure of the lymph node. You can see the non-homogeneous lymph node. Necrosis is there. The most likely patient is diabetic. The high chance of that patient is having tubercular mediastinal lymph nodes. Okay. Put this, clean this, and smear bana. Smear. Okay. Can you put the Doppler another Doppler color? What is this reason? Power dalo, power. Remove it. Okay. Okay. So another pass, endoscopic image. In the same way, you have to again recheck the sheath is out or not. Just crescent shaped sheet should be out. Fix it. Release the needle to, you can fix the length, depth of the needle at which you want to put the under. Again, so this is the, hold it. Again you have to pass this needle, sharpen the needle, taking out the stellate, push, and again put this stellate inside to remove any debris is there or not. Take out completely. Now we have to apply the negative suction in this from बना लिया था नेगेटिव बनाया था हाँ? नहीं ये नेगेटिव था so okay, so this is the way, go fast, go come out or anything, at least 14 to 15 passes, 1 2 3 4 5 6 7 8, but you have to visualize that some vessel is, this is a, you can repeat because you can see formalin. So this, am I audible in the hall? Any question from the hall? So, jaldi karo. We have taken second pass. Core है, core डालो उसमें. There is a good core. Good core tissue. Can you show here? Core. Put this complete core into the formalin vial. So if the core is there, you have to put this in the formalin vial.
Can we see the sample, please?
Pardon, sir?
Sample we can see.
Sample. Can you show the sample here, Rahul? The core tissue. The sample one, core tissue. Core, formalin vial. हिलाओ इसको, चला दो, हिला दो, उधर दिखाओ, और टेप लगा दिया, कोई नहीं. Okay. ला दो, second तैयार करो. So you can here there's a good core here.
Yes.
Okay. So this patient having large necrotic mediastinal lymph nodes, and you can take at least 4 puncture at 4 passes from one lymph node for better accuracy. As you increase the passes number, the yield is increased up to 5. They say that almost 89 to 90% yield is there. So, and in one pass you have to do 10 to 15 jabs at least. Endoscopic image. Fix it. Take out the sheath. Crescent size sheath should be out. Release needle. Take out the stellate and again search the lymph node and ultrasound. So this is the, hold it here. So this is the lymph node. You have to again puncture this lymph node and go.
Sir, can we shift to the live lectures?
Just hold on. Hold it. You know? Take a hold it. Yeah. That is, it is, yes. Yes. निकाल लो उसको. So needle is inside. You have to look needle throughout. Important is to see the tip of the needle. It is not touching the any great vessels or cardiac structures. Negative section. वो नहीं लगा है, क्लियर नहीं किया, चल करो. In this way, we have taken the third pass up from this lymph.
Sir, we are switching to live lecture. Thank you.
For the lecture, I would like to invite as chairperson Dr. Krishanu Banik sir, a renowned gastroenterologist, GI interventionist and hepatologist currently affiliated with Kalyani General Hospital in Kolkata, and Dr. Praful Chavan sir. Please take over the dais, sir.
For the lecture, I would like to call Dr. Sangram sir to continue his lecture.
So good afternoon, everyone. I'll be discussing the expanding role of mediastinal endosonography, specifically EBUS and EUS, in the evaluation of extrapulmonary lesions. Here in Aryavat, we perform both procedures regularly and find combined approach extremely valuable. We'll be covering principles, access, key indications beyond lung cancer. So these are our learning objectives. By the end, we shall appreciate how EBUS and EUS complement each other to provide a near complete mediastinal sampling with minimal invasiveness. This is particularly useful when we are dealing with benign diseases or metastasis from non-lung primaries, where tissue diagnosis drives the management. Before diving into the main topic, let's have a quick lymph nodal station map. So stations 2, 4, 7 are paratracheal and subcranial, central to many pathologies. Station 8 and 9 are inferior and often better reached from the esophagus. Understanding which probe accesses which station is critical for planning. So as far as EBUS TBNA is concerned, it's our go-to procedure for stations 2, 4, 7. Stations 2, 4, 7 and 10, it gives a good diagnostic yield consistently across all indications. Whereas if we see EUS FNA, it gives excellent views of posterior and inferior mediastinum, station 7 posterior aspect, 8 and 9. We can even sample the left adrenal in the same session. Alone, each procedure covers only part of the mediastinum, but together both are very useful. This diagram here, US excels in visualizing and accessing the posterior inferior mediastinum, including lymph nodal stations 4L, that is lower left paratracheal, 5 subaortic, 7 subcarinal, especially the posterior aspects, 8 paraesophageal and 9 pulmonary ligament, as they are adjacent to the esophagus. This makes US particularly useful for lesions surrounding the esophagus or in the aortopulmonary window. In contrast, EBUS provides superior access to anterior and superior mediastinum, targeting stations 2R and 2L, that is upper paratracheal, prevasculars, that is 3A, 4R, lower paratracheal, 7, that is anterior subcarinal, 10 hilar, and 7 interlobal, which align the tracheobronchial tree. So EBUS and EUS both are complementary to each other. EBUS dominates the anterior and hilar regions, while EUS excels posteriorly and inferiorly. The combined approach gives us near complete mediastinal coverage without the need for surgery. And this is why we routinely offer both the procedures when needed. Coming to procedural comparisons between EBUS and EUS, both are safe outpatient procedures, but their strengths are complementary. The real advantage comes from combining them, and studies have consistently shown higher diagnostic reach and yield, often eliminating the need for mediastinoscopy. When should you combine EUS and EBUS? When one modality staging is incomplete, we can combine both the modalities, especially in patients with mediastinal lymphadenopathy from extrapulmonary sources, example lymphoma or metastasis, where diagnostic yield, when we combine both EBUS and EUS, it increases by almost 20 to 30%. Coming to the hardware aspects of both EBUS and EUS, EBUS has a slimmer tip scope with 6.9 mm diameter and a channel of 2.2. It fits the trachea's narrow lumen on an average which is 12 to 22 mm and favors thinner needles like 22 gauge for safer cytology and in the anterior stations. EUS has a larger tip at 13.6 mm and the channel diameter is 3.8, which suits the esophagus distensibility around 25 to 30 mm, enabling thicker 19 gauge needles for core biopsies in posterior areas. In practice, we choose depending on the access and the anatomy. Coming to specific pathologies, role in sarcoidosis. Sarcoidosis is one of the best indications. Patients present with classical bilateral hilar nodes, and EBUS gives us non-caseating granulomas in over 90% of cases, often with just 3 to 4 passes. The yield is comparable to surgical biopsy, but far less morbid. Both EBUS and EUS have the same yield in a sarcoid lymph node. How does a sarcoid lymph node appear on endosonography? It has got a homogeneous appearance, homogeneous echogenicity, which is more common, often appearing as isoechoic to hypoechoic with distinct margins, as you can appreciate here. Another unique feature for sarcoid lymph node, its it has got a sandpaper-like appearance, as you can see in this picture. There are particular signs on endosonography which are very peculiar to sarcoid lymph nodes. The first is conglomeration sign. It's more than one lymph node visualized at a single lymph node station, which looks like a big lymph node with internal septations, if you can appreciate. Though this can be common to tuberculosis also. The another sign which is common to sarcoid is the septal vessel sign. It is seen on the Doppler mode. The septal vessel sign is a finding of a blood vessel that surrounds the lymph node in the color Doppler mode. Both these are common to sarcoid. And as far as tuberculosis is concerned, we have the coagulation necrosis sign in tuberculosis. It appears as a hypoechoic area with lymph node without any blood flow. Coming to tuberculosis, in regions like us with high TB burden, isolated mediastinal adenopathies often raise the suspicion of tuberculosis. Both EBUS and EUS not only gives us histology, but we can send aspirate for gene expert, culture, and sensitivities. The yield is excellent. Emerging data on cryobiopsy suggest even better microbial detection in selected cases. And as seen earlier, how does a tubercular lymph node appear? It has got peculiar characteristics. Here you can see it is heterogeneous EBUS texture, more often seen in tubercular lymph node. The margins are irregular, indistinct, and the coagulation necrosis, which is seen almost 60 to 70% in tubercular lymph nodes. Sometimes calcifications are also seen. More often or not, tubercular lymph nodes are multiple, large, matted, and fused together. The absence of conglomeration sign and septal vessel sign differentiates it from sarcoid lymph node. So how effective is EUS and EBUS in differentiating sarcoid from tuberculosis? It is moderately effective from differentiating both the pathologies, with granuloma detection rates up to 68 to 89% and specificities up to 98% using sonographic features like heterogeneous EBUS texture, more often seen in tuberculosis than in sarcoid. Coagulation necrosis, almost 26 to 63% seen in tuberculosis, and only 3% of sarcoid lymph nodes may have coagulation necrosis. Cryobiopsy improves the yield up to 91%, and if it is combined with tuberculin skin test, the specificity reaches 98% in tuberculosis. Coming to the role in lymphoma, lymphoma remains challenging because we need intact architecture. Previous topics had discussed the role of cryobiopsy. I think cryobiopsy not only gives us larger cores, but what it gives is intact architecture, which will help the pathologist. The conventional 22 gauge needles give adequate material in many cases, but sensitivity is lower than that for carcinoma and granulomatous disease. So cryobiopsy with large core intact architecture has dramatically improved the yield in recent trials, often making surgical biopsies unnecessary in these cases. Here's a look of how extrapulmonary mediastinal lymph nodes appear, or a malignant lymph node might appear. It's round or oval, sharply demarcated, markedly hypoechoic, no central necrosis, typically homogeneous or mildly heterogeneous in appearance. Coming to metastasis from extrapulmonary malignancies, when patients with known extrapulmonary malignancies develop mediastinal nodes, we need to rule out metastasis versus second primary or benign. So EBUS and EUS sensitivity for malignancy exceeds 85%, and immunohistochemistry on cell block confirms the origin. This directly impacts the prognosis and therapy, avoiding unnecessary treatments and confirming the need for systemic options. So you can see here across the pathologies, when both EBUS and EUS are combined, it almost crosses 85% combined yield, and in some cases like granulomatous diseases, it might go more than 95%. Coming to other mediastinal masses like thyroid lesions and intrathoracic goiters, for intrathoracic thyroid extensions or cyst, EBUS provides a minimal invasive alternative to surgery and mediastinoscopy. High yield case series are seen when combined use of EBUS and EUS are done. For bronchogenic and esophageal cysts, they are congenital and often incidental. Endosonography provides definite diagnosis with minimal risk. Therapeutic drainage is controversial due to potential complications. Coming to esophageal cancers, we often in our practice come across esophageal mass lesions which hinder the use of a EBUS scope across the mass for the risk of perforation. In those cases, the solution is to switch to a EBUS scope and have a transbronchial approach to assess the nodes. However, if the airway is obstructed, we can use the EUS and take mass biopsy or the nodal biopsies. So when you cannot go through the esophagus, we can go through the trachea, and when you cannot go through the trachea, we can go through the esophagus. Coming to pleural, spinal and paraspinal lesions, for pleural tumors, example mesothelioma and metastasis, both EBUS and EUS, they can sample mediastinal and paraesophageal pleural thickening, which has shown high yield across cases, aiding to diagnosis and staging while reducing the seeding risk. Spinal and paraspinal tumors, example schwannomas, favor EUSB for posterior access with moderate yields for adjacent lesions. Paraspinal abscesses allow EUS-guided aspiration and drainage in rare cases, providing microbiology for targeted antibiotics. So combined approach maximizes the utility, often obliterating surgery as highlighted in recent interventional pulmonology reviews. So the advantages of combining EUS and EBUS, the safety profile is outstanding. Most procedures are outpatient under moderate sedation. Major complications are just under 1%. We give prophylactic antibiotics for cystic lesions or when there is suspected infection. Overall, this has largely replaced mediastinoscopy in our algorithm. So the key takeaways, both EBUS and EUS especially combined are safe, high yield, and should be first line for most mediastinal lesions beyond lung cancer staging. Cryobiopsy is an exciting advance for difficult diagnosis, and in our practice, this integrated approach has transformed how we manage these patients. Thank you.
Thank you, Sangram sir. Such a wonderful lecture and clear detail, up to the point. And I don't think any has a question to ask. Thank you. Thank you so much.
Thank you. We can call upon Dr. Shushma for a vote of thanks at the end of this conference.
Thank you so much, Dr. Sangram sir, for the lecture, and also thanks to the chairpersons, Dr. Krishanu sir and Dr. Praful Chauhan sir. Now, I would like to invite Dr. Sushma Kaushik ma'am, Chief Consultant Radiologist at Aryavart Hospital, for giving the vote of thanks.
Hello everyone, a very good afternoon. It's my honor to deliver this vote of thanks. Dear distinguished faculty, esteemed colleagues, delegates, organizing committee, sponsors, our academic partner Solaris, a Sun Pharma division, and volunteers, everyone who has made this event possible, on behalf of all the participants, I would like to extend our heartfelt gratitude for this outstanding two days conference on EUS and EBUS. What made this meeting particularly special was the spirit of collaboration between the gastroenterologist and the pulmonologist. The cross-speciality exchange of ideas, techniques, and experiences has enriched us all and reinforced the fact that interdisciplinary learning is a way forward. As we share this knowledge and refine our skills together, the ultimate beneficiaries are our patients, who will receive a better, safer, and a more comprehensive care. With this, we bring this Pulse of Precision Conclave on Mediastinal Ultrasound to a close. Thank you, and we look forward to welcoming you again for our future academic endeavors. I request everyone to please proceed for the lunch on first floor. Thank you.